को जिसमें भी गेम चल रहा है तो उसको बना लो।
यहाँ के लिए ज्वाइन कर रखा है।
यहाँ पे खूब कस के करो। अभी मेरी छुट्टी भी होने वाली है, सुने? हाँ, मेरी छुट्टी होगी 21 तारीख से।
इसी
उसके ऊपर चढ़ना है। ठीक है, बहुत ऊपर। ठीक है। A very good morning to all. After such a long hiatus, it feels great to be here in person amongst colleagues and seniors. I hope and pray everyone is in good health and spirits. On behalf of the workshop organizing committee, I'd like to thank IFS, Dr. Sudha, especially the organizing chairperson, Dr. Nina, our organizing secretary, and welcome you all for this hybrid workshop on regenerative medicine in ART. I warmly welcome you to this workshop to learn from and collaborate with masters and educators in this field. And before we start, we will like to relay a welcome message from the President, Dr. Sudha, and Nina, our organizing secretary. I would also like to welcome Dr. Nalini to say a few words, followed by the lamp lighting ceremony. Thank you.
You will relay the messages first, Dr. Sudha and Dr. Nina.
Dear friends and colleagues, I feel extremely dear friends and colleagues. Dear friends and colleagues, I feel extremely privileged and honored to welcome you all to this academic session of 17th Annual Conference of Indian Fertility Society. Before we get started, I would like to express my sincere appreciation to all of you who generously helped us make this event to become a success. Your passion and ideas have helped us to achieve our goal. Today, I can say that the prestigious Indian Fertility Society has accomplished a recognizable position among fertility societies. It is a pleasure for me to welcome all the delegates of the workshop from all over India on behalf of Indian Fertility Society. Your presence is highly appreciable by all of us. Further, a warm welcome to all industry representatives who are present here to highlight us. I wish you all a great success. Thank you very much. Namaskar.
A very good morning and welcome to all the delegates and faculty for these workshops. The pre-Congress workshops for the Fertility 2021 have been designed and programmed very thoughtfully by the conveners and co-conveners so that the delegates can go back home enriched with knowledge and takeaways from these pre-Congress workshops. I welcome all the delegates, all the faculty who are involved in these workshops, and once again, wish all the success for these workshops. Thank you very much.
Good morning, everybody. Welcome to this hybrid workshop. I wish it had been actually physical. It is still a compromise even when we do a hybrid workshop. But with the corona situation going on and the new variant, we really are in a tight position. So we have to worry about the sensitivities of people. However, I hope that all of you can enjoy this workshop and learn from it, because regenerative medicine appears to be the future. And for many of our patients who are, at crossroads, whether they should go for donor oocytes, whether they should go for surrogacy, maybe this will bring some light and some hope in their lives. And I would like to make a few announcements regarding the change in the program. Dr. Jasneet will be conveying the theoretical aspects of ovarian rejuvenation, and I will actually take over the panel to talk about the practical aspects and the problems that we face. And with that, and also Dr. Firoza Parekh would be giving a short presentation on her work with ovarian rejuvenation with the intraovarian PRP. With that, I would like to invite my faculty, to Dr. Jasneet, Dr. Padmaja, Dr. Shalu, Dr. Suleen, Simran, all of those who are present, please come and let's light the lamp and move towards light, away from darkness. Please come, all of you. All of you who are here, please come on. Everyone who has made the effort to come, please come. Yeah, I was
Saraswati Sharade निस अज्ञान उदधि से, दूर निस अज्ञान उदधि से, पीड़ा पाणी तार दे, तार दे, तार दे, माँ सरस्वती शारदे, माँ सरस्वती शारदे। Hello everyone. I call Dr. Sulain and Sabina to demonstrate for the demonstration of the PRP preparation for intrauterine and intra-ovarian administration. It will be followed by a question answer session, which will be done by Dr. Shalu Gupta, ma'am. Yeah, Sulain. Dr. Sulain Kaun, she did PhD in molecular reproductive biology and she is the head embryologist at fertility clinics in Delhi. And Sabina ka slide. Okay. Sabina is working as a lab andrology lab technician at fertility clinic at New Delhi.
Thank you, Dr. Padmaja. Good morning, everyone. So today I'll be going to give the demonstration for the PRP preparation protocol. So let's first see the outline of the intra-ovarian PRP or intrauterine PRP technique. So these techniques, they are actually the simple 4 steps are there in this technique. The first step is to collect the blood and then separate the PRP via centrifugation. And the step 3 is optional because some physicians, they prefer activation of the PRP. They use activated PRP and some they use the resting or the quiescent PRP for the infusion. So the 4th step is the infusion. I would like to mention here that both the techniques, the intra-ovarian and intrauterine, the preparation method is same for both the techniques. It is only the volume of the blood that we take is different. So we take less blood for the intrauterine, that is around 15 ml. And for intra-ovarian, we take more blood, like 30 ml of the blood is required. Okay. So next is that what all we need for the PRP preparation. So here we'll use ACD solution, which is anticoagulant citrate dextrose solution, and 15 ml conical tubes, syringes, transfer pipettes, and centrifuge machine. The counting chamber and the microscope, these are the optional. If you are doing the platelet counting in the lab, then you need it, otherwise not. So I'll describe the procedure stepwise. So step 1 is to draw the blood, collect the blood, and transfer it immediately to the tubes that carries the ACD solution. So this step is very important, that after collecting it, you should immediately transfer the blood to the tubes that carries the ACD solution here. Okay, and the ratio of the blood and the ACD solution should be 1:4. So if you are using the 30 ml of the blood, that should be mixed with total 10 ml of the ACD solution. So after that, we have to mix the tube very gently, say about 5 to 6 times, and then we have to keep the tubes at room temperature for about 10 minutes. This is a very important step. Room temperature should be maintained at 20 to 20 degrees Celsius, because otherwise, if the temperature is on the higher side, it will lead to the premature activation of the platelets. So throughout the procedure, we have to keep the temperature between 20 to 22 degrees Celsius. So after mixing and after 10 minutes of room temperature, we'll go for the first centrifugation. That is for about 10 minutes at 200 G. After first centrifugation, we'll get the 3 layers. These layers are the upper layer, middle layer, and the lower layer. Lower layer is generally composed of the RBC cells that we don't need it. And the middle layer is a very important layer, which is called as the buffy coat. So this is here, the buffy coat, the middle layer. It is also known as the PRP, that is the platelet-rich plasma. The upper layer here, the upper layer is called as the triple P, that is the platelet-poor plasma. So after this, we have to transfer the supernatant, which is composed of triple P plus the buffy coat. We transfer these 2 portions into the fresh tube. But before going to that procedure or the step, I would like to mention here that in this picture, you can see 3 tubes, and I would like to put your attention towards the fraction and its importance. So in tube 1, the tube A, the fraction is just above the buffy coat. If we analyze this, then this fraction has the platelets, average amount of platelet, and the very less leukocyte. Yes, this one. So this fraction, this yellow part, just above the buffy coat, it has very less leukocytes and average amount of platelets. And in tube B, you can see the fraction which is little above with a gap over the buffy coat. That fraction has very less platelets and the leukocytes. And if you see the tube number C, this fraction, which includes the buffy coat as well as the little above area of the buffy coat, this fraction is full of platelets and leukocytes. So this fraction, we call it as the LPRP, that is leukocyte-rich platelet fraction. So LPRP is, it has high concentration of platelets as well as the growth factors. And secondly, it has been shown to have a positive effects on the endometrial healing receptivity and the implantation. So basically the leukocytes, having leukocytes in your fraction is good because leukocytes have been shown to have the positive effects on the endometrial receptivity and the implantation. So let's go back to the step. So what we'll do here is we'll transfer the whole supernatant here with the buffy coat into the fresh tubes. So first we'll take the supernatant triple P fraction, and then we'll take the buffy coat. While taking the buffy coat, one has to be very careful because we have to avoid the RBCs, but we have to take the buffy coat as much as we can. So there is a little bit contamination of the RBCs that will come, but that will increase your platelet counts. So after this, after taking this buffy coat, then we'll go for the second centrifugation, which we'll do at 500 G for about 10 minutes. So after second centrifugation, you'll get 2 layers. One is the supernatant, and the second layer, that is the pellet, that is the white pellet. These are the 2 layers, and we'll have the supernatant and the white pellet. So here I have included the white pellet or the fraction from 2 different patients. This is the patient number 1, where you can see the white pellet. The white pellet is little less. So this is the patient that has low on platelet counts. And I have included the another patient fraction also here. You can see the white pellet is thick. It's a good amount of platelets that we have in this patient. Okay. So then the second step is to remove the supernatant and leave only 0.5 or 1 ml of this plasma or the supernatant so that we can mix the pellet within that plasma. So whether you have to take the 0.5 ml or the 1 ml, that depends on the amount of or the thickness of the pellet that we achieve. Okay, so because this was from the first patient with the less pellet thickness, so we are dissolving it, we are mixing it in the 0.5 ml of the solution. So this we'll call it as the, after mixing, this is the resting LPRP fraction, which is ready for the infusion. Okay. So then the next step is the activation of the PRP, which is optional. Okay. So before going into the procedural method, I would like to introduce the platelets and the activation. So on the left side, you can see here, this is the resting platelet, which has dense granules and alpha granules. So these dense granules are generally smaller in size, and they have magnesium, calcium, zinc, and ADP molecules. And the alpha granules, these ones, they are the bigger in size, and they have the majority of the growth factors. And they play a very important role, and other important proteins also. So what happens when the activation occurs? So there occurs the two important key processes when the platelets get activated. The one is the degranulation of these granules. The step one, the first key process. These granules, they undergo degranulation and they release the growth factors into the supernatant or the fraction that we have. And the other important step that happens during activation is the fibrinogen cleavage to initiate the clot formation. So this fibrinogen cleavage, there occurs this extension of the platelets. It happens. One can see in the electron microscopy also that when these platelets, they get activated, they undergo these, they develop these extension, and these extensions, they help in binding and formation of the clot. And as you can see here in the resting platelet, there are many of the receptors present, and there are many different modes of activation or the triggers that can happen and initiate the activation. So coming to the activation part, there are mainly two different methods of activation. One is the mechanical and the second is the chemical. Let's come back here. Okay, so the mechanical and the chemical activation, these are the two different mainly used in the research. So the mechanism of action is different. Like in the mechanical, there is a sudden heat shock that causes the platelet destruction of the platelets. It causes the physical destruction of the platelets and thus causing the release of the growth factors. And in the mechanical method, you actually cannot see the clot formation as such. And in the chemical method, if you say, take example of calcium chloride, it reacts with the plasma within the PRP and it activates the thrombin. It produces the autologous thrombin, which activates the platelets and the growth factors and also solidify the plasma by creating the clot. Okay, so there are little drawbacks of both the techniques. One is that mechanical is some authors, they believe that it is less effective, but it is not sure. However, the less effective, they are saying, the rationale for saying that is that the concentration of growth factors that we see in the supernatant after mechanical activation is less, whereas the amount of growth factors that you see in the chemical activation is quite high. Talking about the chemical method of activation, the one thing is that it involves, the drawback is that it involves the chemical, the outside material to activate it. So that's one. And the chemical is generally used for the activation is, it can be native, which is ADP, collagen, or the magnesium, or people also use the exogenous molecules like calcium chloride, calcium gluconate, or thrombin, and there are a lot more. So the second drawback of the chemical method is that it accelerates the gelling of the plasma. The supernatant that we have after the clot, the supernatant that left is quite jelly in the material, which is difficult to infuse. Okay. So the important point here is that different mode of activation, even the mechanical, or if you are using chemical, if you are using calcium chloride or thrombin or whatever chemical you are using, the different mode of activation will activate or influence the composition of releasate. Releasate, I mean that the different growth factors or the important proteins, they release into the supernatant, and that depends on the mode of activation, that which signaling pathway is getting triggered and getting activated. So because of this factor, it is very, very important to standardize or to adjust your model, that what chemical is giving you maximum response. So first we'll cover the mechanical method. Here, this includes, after getting that resting PRP, LPRP, we'll transfer the LPRP 1 ml to the vials, and these vials will we'll keep it in the, immerse it in the liquid nitrogen for 5 minutes. So this, under this mechanical method, we are doing freeze thaw cycle for about three times. Okay, so we are immersing it in the liquid nitrogen here, and then we are keeping it here for the 5 minutes, and then we are transferring it to 37 degrees Celsius for again 5 minutes, and we are repeating this cycle for 3 times. After the last 37-degree incubation, we'll centrifuge the vials, and then we'll take the sediment that has the platelets. This is all about the mechanical method. This is the chemical method. This is a very good slide by Cavallo. So what they have done is that they have they have checked the clotlet, the activation process by using different chemicals. So this is the tube number 1 is the calcium chloride, then the thrombin, and then the mixture of both, and then the collagen. And this last one is just a simple triple piece, poor platelets. Then they have seen that the chemical methods, they have initiated the clot formation, as you can see, but the collagen and the triple piece solution, there was no clot formation even after keeping the tube for the 24 hours. Calcium chloride is little slow, but not much. But the thrombin, as compared to the calcium chloride, it gives a very quick clot formation. So the method includes the addition of 50 microliter of 10% calcium chloride to the 1 ml of LPRP, and then we have to incubate it for 30 minutes at 37 degrees Celsius, followed by centrifugation, and the supernatants, they were examined and used for the infusion. So if we compare the resting PRP with the activated PRP, so both the fractions have been used in various ovarian regeneration studies. So resting PRP, if we inject the resting PRP, it causes, what is the action, how it gets activated in the body is that when we inject the resting PRP, it causes the spontaneous platelet activation when it binds with the collagen, that is the native collagen present in the connective tissue. And this causes the slow releasate process, and it is quite for the longer duration as compared to the activated PRP. Whereas in activated PRP, the growth factors, this secretion begins within the 10 minutes of the PRP activation. And these growth factors, they have a very short half-life from minutes to 24 hours, depending on the growth factor type. And if they are not used immediately or infused, administered immediately, they might be degraded even before binding to the receptors. So the other slide is showing the concentration of the platelets here. This is the whole blood, which has very low concentration of the platelets. This is the triple P, poor platelets, poor plasma. And this is the PPRP. And this is the finally with LPRP, that means the fraction that has the buffy coat as well as the triple P layer. So this has the highest concentration of the platelets. So this is all about the methodology or the procedures PRP preparation, and whether you are using the resting or the activated PRP, we'll take it in the syringe, we load it either 0.5 ml or the 1 ml, depending on the size of the ovary and many other factors. And these fractions are ready for the infusion. Thank you so much. Thank you. Thank you, ma'am. Yes, please. Okay.
Using more, right?
Yes, the blood, volume of the blood, we are using 30 ml. Yes, that again depends on the many factors. What is the size?
Institution for the same. Dr. Shalu Gupta, she is an associate consultant at Cloud9 Hospital, Gurgaon.
So I have few panelists who are present in person and few are there who are present online. So online I have the ones who are present is Dr. Achal. Dr. Achal is a Associate Director, Cloud9 Hospital at Punjabi Bagh branch. And I also call Dr. Simran. We have 2 chairs here. We need only 2 chairs for my panelists. And then Dr. Simran is a Scientific Director and a Senior Consultant at Reproductive Medicine at Little Steps IVF, New Delhi. My panelists who are joining online is Swati. She's a Senior Consultant at Jindal IVF Center. And Dr. Sankalp Singh, who is the who's presently working as Director, Yami Fertility, Indore, MP. Please, can I have my... So, so let's keep this as an interactive session because there's a question and answer session. And we all know that PRP is something which is new. So we'll be sticking to what we call as the technical aspects. We are not going to go into theories because we still have a lot of theories which is going to happen. And in this question answers, we'll be talking about PRP in endometrium only because we have a panel in PRP in ovarian, all that stuff. So we'll just talk about PRP in ovarian, the technical aspects of it. So my questions first, we'll speak to Surleen. Surleen, after your talk, I have so many questions in my mind which is going on. So my PPT will not be coming up. नहीं तो फिर मेरी शक्ल की जगह PPT दिखा दो यार. And my panelist also. I just don't want. हाँ, panelist, you can put it in the sides. Hybrid.
I didn't want to have it.
No, but I want my panelists also to come on the sides. Achha, okay. So we have all now come to know what is, we understood from Surleen what is PRP, that is cytokines and growth factors which help in regeneration. So this is the things which is, we are very clear in it. So now we come to techniques we have spoken. Surleen, I just want to understand. So you are saying to put a leukocyte rich or a leukocyte deficient, what is more beneficial? That's okay. Okay, okay. Huh.
Yeah, clearly it is the leukocyte rich fraction actually which will be more beneficial because it has, as I've shown in the
Previous.
slide also, that it has a more concentration of growth factors as well as the platelets. And secondly, that the leukocytes, having leukocytes in the fraction, the benefit of, as it has shown, the positive effects on the endometrial healing, receptivity, and the implantation. There's a paper in the Nature that shows this.
And you do not say that we should use activators. You say, let's go with the natural thing, because when we're using the activators, it will prolong the time from the formation of the PRP to insertion. So we should not be using the activators. That is what I understood, whether it's thermal or a chemical. So no activators. So what is the time duration you say when? Yes, ma'am. Sure.
She did not say no. She said there are positives and negatives to both sides.
Yes.
Some people do use activators because they feel it's going to be better, it will work better. And others feel that if there's a delay in the time from when you make it to when you insert it, it may actually growth factors may already degenerate and then not attach.
And what is
So
the
there are pros and cons.
what is the time you normally do? You use it in your practice? Let's come to this.
No.
We are not using in your
We are
practice.
about to going to use it so that we can have a comparison of both the groups without activation and with activation. Now we have done many patients without activation, that is the resting PRP.
And one thing you said, to keep the temperature between 20 to 24. That means that time your AC, when you're preparing a AC, your AC goes to 20 degrees centigrade.
Yes, 22.
22. But then when you're doing the thermal thing, you're putting it to 37 degree also, freezing 37, freezing 37. Then won't the 37 degree hamper my?
No, that's actually yes, purposely we are doing it because we have to give heat shock, the physical damage to the platelets so that growth factors can come out.
But then when this growth factors come out, how much time should be there from the preparation and insertion?
The growth factors?
When you're activating?
10 minutes.
10. And otherwise, normally how much you time?
It is 10 minutes.
Wait, when you prepare it also, within 10 minutes, for the resting one, yeah.
For resting, we generally immediately infuse it. We prepare it just before the administration infusion. We prepare the sample and we just within 15 minutes we give it to the clinician for the
So
No,
then
no,
you need
because-
to understand this ki
Tanya,
once.
just a minute. Because if you are going to keep it, by and large, that's what's done. It's prepared and put in. But if you're going to keep it, it has to be kept at 4 degrees centigrade for a while, but you should not keep it for too long because whatever you're wanting to achieve through the growth factors is not going to be there.
So that is what I want to tell my the audience, everybody, that once these people in the lab say it's only 10 minutes more for the sample to be prepared, please prepare your patient so that those things should happen side by side. You cannot be like, okay, I'm busy in my study, prepare the sample, keep it there. You need to be a little more forward to it. Your patient is prepared side by side, she's ready. So once you get the call, 10 more minutes for the PRP to ready, your patient should be in position that once it is ready, immediately it comes and you put it in. So there is a...
So that's the time we get a patient into OT position, done and
that
ready.
Is what I'm trying to
so
tell.
Then they come to us, we are there. And if you don't have that position, as ma'am said, choose your patient, then do the natural process. Then you don't have a stress.
But even the natural process, Tanya, you need to put it in 30 minutes. Yes, correct. But you need to prepare the patient. That I know.
Let's move on to the
Next,
question
take it.
because the time
So
is-
I'll not going to speak much.
Add one more thing here because people who are using the activated PRP, they are keeping it for a longer time, infinite time, in -80, and they just freeze thaw them. They just thaw them before infusion.
So I'm not going to go much into this now. So what is the ideal concentration you're looking when you're putting the PRP?
It should be at least 1 million per microliter.
And if you're not able to achieve that the concentration, do you check it once you prepare the PRP or you're not checking it?
We are not checking it, but we definitely give the sample to keep it in our record and see what is the response is. So we give it, outsource the sample.
How do you
platelet counts? Yeah, we'll check the counts and whatever pellet we achieve, we dilute it as per the thickness of the pellet, either in the 0.5 or 1 ml, and then later on we get the count.
And if you're not able to achieve the same count, then 1 million you're not able to achieve.
We generally do
You
because we
generally
take 30 ml blood and we generally
This
know.
is, you
It
are taking not
almost-
over, we're talking about endometrium.
Endometrium.
30 mm you said for the
Intra-ovarian,
ovarian. We are
yes.
talking about right now endometrium.
Endometrium, we generally give, we are getting more than 2 million count. We are not getting less counts.
Okay. So I'm not talking about kids.
So
And
we are actually getting many-fold increase. So I have noticed that it is always more than 2 million, and the fold that we are getting is about 6-fold increase up to 22-fold increase that we are getting.
25 also in some of.
Yes.
Yes.
So maximum.
Okay. So I am my now comes. Thank you, Suli. So my now questions goes to the clinicians. You can give the mic to them. Achal, do you have any? We all know that we are using the PRPs being used: thin endometrium, recurrent implantation failure, endometritis, and Asherman's. And the two procedures we are doing is hysteroscopic as well as intrauterine insertion. So PRP, is there any prior consent you take from the patient? You're doing it. And do you speak, and how do you do a patient selection?
See, as you already elaborated, PRP is to be done in very selective patients, patients whose endometrium is not growing up to the mark, which we, the lower cutoff that we take is 7 millimeters. So if you have monitored the patient and it doesn't show any improvement despite giving estradiol, valerate, and all the adjuvants that you want to give for 2 cycles, that is the patient you would counsel for PRP therapy. And if there is a prior history of Asherman's or endometritis, preferably a hysteroscopy should have been done so that any synechia, if they were there, have been taken care of. And now you are just focusing on the proliferation of endometrium. So after all that groundwork has been done and you are not getting any results with the regularly used adjuvants, that is the patient you would want to counsel for a PRP therapy. And the patient needs to be made aware of the procedure, of the disputable results. Still it's not an established therapy, still we are not 100% sure it's going to work. So it's very important to make the patient aware that now that everything has been tried, we are going to try this as the last resort, and whether this will work or not, we cannot guarantee you about that. As far as the side effects are concerned, we know that it is autologous, so we are not worried about the side effects.
So, Simran, do you want to add anything? Swati, do you want to add anything to it?
Like consent, as in every procedure we do, little bit consent, telling the patient that it is still under trial or experimental process.
Anything add-ons which apart from she said? I think
that's
Swati, do you want to add?
Practically a safe technique. We don't get much immune reactions or the other infective kind of reactions because it is autologous. But still, my question is whether is it required FDA approval to use this treatment, or because in India we are not. We are in fact, all over the world, we are doing it as an experimental and researchers tool. So my question here is to, does it require FDA approval, or it's
Santa, do you would like to add to this? You've been doing it. So did you require FDA? I don't think so. They've required anybody. They're just talking to the ethical committee. Madhuri ma'am, do you want to add anything to it?
No, basically you require an ethical clearance, but most of the Indian guidelines, they're not included PRP or the autologous bone marrow in their guidelines. So we are not very sure as to what to do, but I know that Dr. Sunita, who's doing it for many of her patients, she has got her permission from the DCGI, and she has put up, and then she also takes a video consent from all these patients when she's using either PRP or she's using the bone marrow stem cells.
So even for PRP, Madhuri?
Yeah, she's
PRP is a, it's just a blood product which you're putting
but
in.
then
So
she is taking, and she has also
it's safer that way.
Yeah, I think, and she's got the permission for DCGI.
Sankalp, what about you?
Firstly, good morning. Thank you for inviting me for the panel. Regarding the ethical, the clearances which we need, I think the PRP doesn't need a DCGI approval. The stem cell definitely needs a DCGI approval, and you should be going for it. For PRP, since what Nalini madam said, it's a blood product and it doesn't need a DCGI approval. Regarding FDA approval, there is nowhere in the world that FDA approval has been given for PRP usage. And it's not just PRP. There are many such medications which are used in reproductive medicine where they don't have the FDA approval.
Add-on therapies.
Yes, all the add-on therapies, whether you see GCSF or IUHCG, they don't have the approval for the from the FDA. So what we do practically, we take a 3-page consent form is there, which is having all the details that it's a research modality because it's not a proven method of therapy. Whether you're talking about uterine, whether you're talking about implantation issues or thin endometrium, or whether you're talking about ovarian issues. So we don't have, it's not a standard of care at present. So for anything, we should be always legally on a safer side. So we take a total 3-page consent form, which has all the details. It's a research modality. It's not a proven method of therapy, not a standard of care. And if you are willing for it, if you want to try it, knowing the experimental nature, you can go for it. So that's how we go about the therapy.
Sankalp, I just wanted to ask one thing, if Shalu allows. But I was just thinking that, where we are giving empirical therapies in the form of low molecular weight heparin, immunoglobulins, there, what are the consents that would be taken? Because if you look at it, it's very similar to that. In fact, it is autologous, whereas when you're giving immune therapies, they're not even autologous. When you're giving IVIGs and other stuff. So what are the kind of consents one should take for that?
Madam, when we are using, because we don't use immunoglobulins, we do use intralipids. And when we are using intralipids, again, we take a consent. It's not as detailed as PRP because PRP is more invasive compared to intralipids. So we take a 1-page consent for that, as well as when we were using GCSF for many patients with thin endometrium. So then also we used to take. The question here is that as we know right now that the ART is getting regulated and the bill is just going to get passed. So then I think the problems which we were not facing till now, we will be facing in the near future. And then we will be answerable to the government and to the people, both of them, which many of us used to escape from right now. So I think this is the time where we should be more cautious about our approach. As you said about low molecular weight heparin also, I don't use it in RIF patient because there is no evidence of using it. I used it earlier. I didn't get any benefit. So I've stopped using the therapies, the low molecular weight in RIF and immunoglobulins. I've never used it.
Now, Sankalp, if you're using PRP, could you tell me which day of the cycle are you using and how are you repeating it so much, how many times? And if you're not getting the adequate thickness, are you canceling the cycle? And if yes, are you doing it again in the next cycle? These are my few questions which are coming up next.
Just to answer in quick succession, PRP, we used it for thin endometrium earlier. That was a few years back. We did not get good results. We have stopped using PRP for thin endometrium. The preparation method for us, but what we are doing PRP is the same as what Dr. Surleen has explained, the 2-step, the soft spin as well as the hard spin, what she explained. Regarding the implantation, we used it for recurrent implantation failure. We had a paper published in First Science last year, which came up in which we had 142 patients in the PRP group and 154 in the control group. So we did, for 33 patients, we gave it by the subendometrial injection, just between the endometrial and myometrial junction by using a 2D ultrasound. The second one, that is 109 patients, we gave it intrauterine. We got better clinical pregnancy and ongoing pregnancy rate in the PRP group. It was not different between subendometrial and the intrauterine groups, but it was both were higher than the control groups. But it was not a randomized control trial. It was a prospective observational cohort study. So I'm still skeptical, and I still would suggest everybody to use it as a research modality, not as a standard of care, because we really don't know how the things are going to unfold in future with the changes in the law.
So what about Achal and Simran? And are you using it?
Ma'am, I'm using only intrauterine method and not the subendometrium
For what
method.
you're using? For endometritis, everything, or just for the thin endometrium?
For thin endometrium as well as in patients of RIF.
Ah.
For thin endometrium patients, I use in around 10 patients, but not, didn't get any benefit. Although 2 patients conceived spontaneously. For RIF, I am using it, I've just used it in 2 patients and I have to see whether they conceive or not.
And what are you cleaning the beta? You're cleaning the cervix. Are you giving an antibiotic during that
I'm
time?
giving post because I'm giving antibiotic cover for a day, azithromycin 1 gram, but I'm not cleaning it with betadine. I clean it with normal saline before I start.
What about Angela? What about you?
See, I think we can take the procedure as we do the IUI, because even in IUI, we are not cleaning with betadine. It is gametotoxic. We are treating the fertility patient and it is autologous. So I don't think, if you don't see any active infection, if you don't see any indication, there is no need to clean with betadine. You can simply, if you want, there is mucus, you can simply clean with saline. And once you instill it, antibiotic, according to me, is not required. We do not regularly give antibiotic in our IUI patients. And intrauterine instillation, according to me, does not require any antibiotic or adjuvants.
Ma'am, any expert comment here? Dr. Madhuri?
No, I don't think an antibiotic would be required unless you're injecting it subendometrial, wherein you're going to go through the endometrial tissue. So if you're just inserting it through the, just like an IUI, I don't think an antibiotic cover is required. And I think just cleaning with saline is enough.
Ma'am, do you have any experience doing it hysteroscopically?
No, I don't have.
Sankalp, you?
Yeah, we did hysteroscopically.
Could you explain the
sometime
procedure
back.
to all our delegates here once? How did you do it hysteroscopically? When did you do? Because I don't think so. Actually, you've been doing hysteroscopically. I don't think so. Anybody else has done here
We are
hysteroscopically.
also not using hysteroscope.
So can you just explain the procedure and everything for us, for a
yeah,
benefit for us?
Yeah, I can explain it, but if you ask me the gist of it, I didn't see an improvement with by doing it hysteroscopically. So hysteroscopically becomes more of a blinder procedure compared to a subendometrial, because in subendometrial you're seeing with the scan, and then you are injecting your needle accordingly. But with hysteroscopy, you have two separate screens to look into. You have to look into the hysteroscopy screen. You have to look into the 2D ultrasound screen if at all you're doing it. So what we used to do hysteroscopically is we used to put the hysteroscope, take the and load it in the needle, and after that we used to just inject it subendometrially. Again, it was a rough estimate because we used to see the endometrial thickness before doing the hysteroscopy. So we used to know, okay, the endometrial thickness of an anterior wall, because that's a point we used to usually go into, because hysteroscopically it's difficult to inject it in the posterior wall because the needle is rigid. So we used to go into the anterior wall most of the times, and so we used to measure the exact thickness of the endometrium in the anterior wall of the uterus, and then by a rough estimate we used to enter in and then see it into the 2D ultrasound image and inject it there. But then what we found was we didn't find any much difference in doing it hysteroscopically. It used to be much more costlier to the patient because an additional procedure was necessary. For the patient, anesthesia was necessary. So then we reverted to a subendometrial, in which we used to do it operating in the IVF OT itself, where we used to just do it under ultrasound guidance. We used to thread a needle, the aspiration needle, through the IUI cannula itself inside. For that, the important thing is that the cervical canal has to be straight, or it has to be maneuverable. We cannot do it when the cervical canal is bent and either acute anteversion or acute retroversion. So the patient identification and the ultrasound scan becomes necessary to see the cervical canal. So then we used to put the needle, thread the needle through the IUI cannula, and then put it in the anterior and the posterior vaginal wall. 2 ml, we used to put 2 ml in each anterior as well as the posterior vaginal wall. And then we used to come out, watch for the bleeding, and then discharge the patient in the evening.
Okay, I just...
What needle did you use? You use the same
The normal aspiration needle, madam.
Okay.
So same aspiration.
Did you use the operative hysteroscope to put in the needle?
No, madam. We just used we used to cut it near the hub, and then we used to close it with an artery, and then we used to thread another needle which used to push the PRP inside so that it comes up to the tip, and after that we used to insert it in, and once the insertion is done, once it is in place,
Along with the outer sheath of the scope, you used to push it in.
no, madam. It was just the
IUI catheter, ma'am.
needle
It was with the
attached
IUI
to
catheter.
the IUI catheter.
No, when you're doing it hysteroscopically.
Hysteroscopically, yeah. That time we used to just thread it through the inner cannula. That time, through the hysteroscopically when we used to use. That time the main aspect.
Oops, what happened?
I think his video.
I think the connection got lost here.
We lost the
But what I wanted to actually ask him was that when you're putting in 2 ml subendometrial, how much of it actually falls out into the endometrial cavity? I think that is a more practical question that one has to look at, because if you're going to go very deep into the muscle, you'll go into the muscle, because the endometrial, subendometrial tissue is hardly anything there. And how many times are you going to come, take it out, move into another direction, which with an IUI cannula is, I think, going to be next to impossible. So most of what you're putting in would actually be coming back into the endometrial cavity, and unfortunately you've lost connection.
Ma'am, I was going to search, did a net search where we got a paper from Maharashtra. Can you just show my slides, please? So I have some pictures from that paper. They said that they have been managing thin endometrium by hysteroscopic instillation. They did some 140 patients. They prepared 4 ml of the PRP solution, and they had put it through the pickup needle, 1 ml in each needle. So what they had used the OPU needle, keeping the beveled edge of the OPU needle facing the endometrial cavity so that there is no penetration. So these are the slides. They did it in a cycle prior to the periods, because you cannot do the hysteroscopy during the preparation. This is the first image where they showed, my precursor is not working. This will,
you can move it forward.
No, there is no, okay, no, that's not. These are the just images, the hysteroscopic installation of the PRP, the beveled edge or the OPU needle was oriented, was kept for the orientation of the depth of the insertion. So in the next thing, the marking of the OPU needle helped in determining here they said this help us to determine the marking of the OPU, help us to determine the correct depth of insertion. Prepared PRP is pushed in the endomyometrial junction with the needle, and the needle is withdrawn under vision. No leakage of the injection fluid was seen on the withdrawal of the needle, and PRP was instilled within 20 to 30 minutes, as we already spoke about.
Okay, just one point here which I want to make. You're doing hysteroscopy with fluid under pressure. How on earth will you be able to see whether the fluid has come out from that after you've withdrawn your needle? So that's a very practical aspect, because it's fluid going under so much pressure. How do you know what has come out from there?
This was only one paper with some images which showed us.
And I think all the practical points I've spoken to Dr. Nana Patel, and I've asked her when you do it hysteroscopically, and really when I've done it, I was as confused, did it actually go in or have lost it, and that, so it will. So what they said, which practically they say 4 ml, take much more. So he said take 8 ml. Because one, you're going to flush it through, some will be lost. And in this paper, so we looked at this paper only, Shalu, and then I think Dr. Nena is there today also. So what they do is rather than 4, they said do about 6 to 8 and be very careful and see the blanching, because there will be some loss. And I think you have to put the practical points, and even when you put the needle in, you have to be very careful, as ma'am has said, because that subendometrial area is very, very thin. You're not going to go into the muscle. So as sir said, we didn't do it with ultrasound guidance, and probably that's a good tip, but we were getting confused. So Dr. Sankat, we did it hysteroscopically without the ultrasound, just looking at one camera, and with the preparation before you've seen the patient, you've done the thickness just before OT, and then we didn't do it simultaneously with both.
So
Shalu, I just have
Dr. Sankalp, my question is just when you insert the PRP into subendometrial plane, so did you notice any elevation of endometrium? How do you ensure that all the PRP has been deposited into the subendometrial plane?
There was a blanching and a blood.
Because it was a 2 ml, it's a quite big amount.
Hey, as we have just discussed, the hysteroscopically, I would not suggest to use it because there are practical issues. Plus, there is no additional benefit of doing a hysteroscopy unless and until you're doing it for a patient for a diagnostic purpose as well. So the subendometrial, when you're injecting, the problem is, as you said, when there is a very small amount, there is a probability that you might be able to see it on the ultrasound. Okay, when you're doing the 2D ultrasound, but it depends on who is showing it to you and how good is the ultrasound machine and how good is the depth, whether there is obesity or not. So what I used to prefer is I used to go subendometrially, I used to ensure the position, and after that my eyes were totally into the needle hub, and I used to see there that okay, this is the amount which is supposed to be pushed in, and then I used to go in to ensure that this much amount has been deposited, and my finger used to give a pressure once that 2 ml used to reach. So it was 4 ml at the time when I start pushing. It used to come at 2 ml and then stop there and wait for the time that around 5 to 10 seconds and then withdraw the needle. Then the important point here, as madam pointed out, I think it was Nalini madam, that there'll be good amount of fluid which will be lost in the dead space. So what we used to do is we used to always measure when we are pushing first the PRP as to how much amount of fluid is required to go from the tip of the syringe to the needle tip, and then the same amount of platelet poor plasma we used to take and push it when you are injecting in the second wall.
Yeah.
So the first wall, that is the
Sankalp, can you just, I didn't ask that question because it is very obvious, like we do for an IUI, you'll always account for dead space. What
Yes.
I asked was because the hysteroscopic is going under so much pressure, how much, and you're distending the cavity, and the moment it collapses and comes out, how much fluid do you think oozes out of where you've put it? That was my concern and question.
The needle point.
That is a very valid concern, madam. So hysteroscopically, we used to wait for around 20 to 30 seconds before we take out the needle. But again, as you said, the fluid can go in any direction. So even with the small needle hole, the fluid can go in and actually it can wash out the PRP wash the PRP outside. So that's also one of the reasons why we stopped doing it hysteroscopically and went for subendometrial injections.
Madhuri ma'am, do you want to add? You wanted to add
No,
something?
I have Dr. Sunita's video done hysteroscopically. Do you want me to show it?
No, Madhuri, I think hysteroscopy is not the way forward, so I don't want to waste the time.
Conclusion that hysteroscopy is not the way forward because it's too much cumbersome and too much things are involved. Plus, when we're doing subendometrium, we are even touching the our endometrial myometrium junction. So are we instilling adenomyosis, endometriosis, the one which had a basic pathophysiology from there? We do not know what are we going to cause in these patients in future because this is still started somewhere around 5 to 7 years back. So what if these patients come back to us after 10 years saying we've got adenomyosis, endometriosis? So we may be landing up lots of problems here. So then again, because we are putting growth factors, there are issues about endometrial hyperplasia, endometriosis, and then risk to the children who are born with, we still have to go through it. So
in addition, one more practical complication that can be anticipated in these patients is once you make a puncture in the endometrium, and you have withdrawn your needle, after that you make another puncture. So you've left that hole open, and with the fluid going in, are you letting fluid embolism or air embolism happen through that? Because you have punctured till the endomyometrial junction where the vessels would be. So embolism is another.
I think it's a valid concern. However, I also think that I don't think you are, making such a big puncture, and it would only if you go directly into the vessel that, there would be more risk of that. Of course, there are people who are very high risk takers, and you never know what they do. You have to keep these things in mind.
So my last question to my panelist is, supposing you're not able to achieve in my first cycle in thin endometrium or in the recurrent implantation failure, a pregnancy rate. So are you going to plan another cycle with the same protocol or you change your protocol? That's my question here. So if you're not able to achieve your lining thin, so what happens in next month? Are you going to offer the same treatment or is just one time treatment? What is it?
Actually, studies have shown that one cycle should be good enough, but if we do not achieve, we can always counsel the patients. We can try for another cycle, maybe 2 to 3 cycles we should be trying before we finally tell patient that we have not getting the adequate
But you do
results.
hysteroscopy, but before offering PRP, we need to do in patients with thin endometrium, we need to
Definitely, we need to
complete
do the
our
hysteroscopy.
previous
Yes,
old
definitely.
protocols during the hysteroscopy,
We'll be
make
looking
sure
for
there's no
any
addition,
tweak
and then
and
only should
yes.
land up into PRP as a
Hysteroscopy
last.
should be the first
Yeah.
step. to
Okay,
look
so
for
now
sanity and
I want to ask a question, and I think I would ask Sankalp and Madhuri, because they are the senior people sitting over here, is that when we are putting in PRP with all the growth factors in there, suppose there is a pre-existing chronic endometritis, is there a risk of flaring it up? Also, when you're going vaginally, because there was a lot of discussion on whether betadine should be used, there are so many patients who have undetected vaginal infection. If you're not cleaning with the proper antiseptic solution, it is not germicidal. You can always clean the mouth of the cervix with saline thereafter once you clean the vagina properly. So that has always been my concern and always been my worry. Are we introducing anything, because these are these growth factors, and you can have a nice growth of whatever was subclinical there now flaring up into a clinical. So that's a worry. What do you feel about it?
Madhuri ma'am,
Yeah.
you would
Yeah.
like to take it first?
No, what Dr. Nalini is saying, I also agree with her. But I think even when we're doing an IUI also, probably there is also, at that point of time also, there's a chance of introducing.
No growth factors there.
Yeah. Yeah, that is also there. I mean, there could be chance, so then I think you think that giving antibiotics is a better option after doing it?
I don't know. I'm asking you guys the question because it's a worry. You're putting in nice growth factors there. Yes,
what we used to do is for all patients which we are doing subendometrial PRP, we used to give them around 3 days of we used to do cervical swab for all the patients as usual. 3 days of clindamycin and clotrimazole pessary we used to give them beforehand, before we took a sample for the PRP, thinking that if there is a vaginal infection, indolent infection which is undiagnosed, it might help in reducing the severity of it, reducing the amount of colonization which is taking place. But as you said, those risks would exist, and these are the risks which I would suggest everybody to note it down, because our consent form used to note down all these things, including infection, because it's an invasive procedure. So if at all any problem comes in, we cannot escape from it. Just one more point I want to put in regarding Shalu's question for thin endometrium. We have used tamoxifen for thin endometrium. We had a ISHRE paper which Dr. Swati, my wife, presented in 2015. And for thin endometrium, I find excellent response with tamoxifen. So we actually stopped using all GCSF and other things, and I think that it is of much better use than even using a PRP for a thin endometrium, because I did not get response with PRP, but I got excellent response with tamoxifen.
Sankalp, I would like to add over there. I've been using tamoxifen for a very long time for in patients who have thin endometrium. But you must remember those are the only ones where it is going to work is if the receptors are there, if the endometrium is not damaged and the basal layer is not fibrotic. It's not going to work in the other lot, which we are trying to do through the regeneration. Madhuri, sorry I interrupted.
No. Yeah. But I think in these patients who are having thin endometrium, it's best to do a hysteroscopy. And if you find that there's no pathology, I think then using tamoxifen is a good option, because I do use in quite a number of my patients, and I too have got good results with tamoxifen. But I always do a hysteroscopy before I go ahead and start using tamoxifen.
How often do people check for chronic endometritis when you're doing hysteroscopy in a thin patient with thin endometrium?
Yeah, so we normally do a biopsy, endometrial biopsy, and like I had a patient just 3 days back wherein it gave a classical picture of chronic endometritis, and I just wrote to the pathologist that you please do see for plasma cells as well as you do the immunochemistry, but it did come negative. But then to be on the safer side, I given her doxycycline, because that seems to be the best drug for chronic endometritis, because the picture looked like that, but on the histopath or the immunochemistry, I didn't get any this thing.
Yeah.
But about the LS and EMA, I don't think many patients can really afford it.
Yeah, yeah, it's too expensive.
Paying about 30,000. So I have done in about 9 or 10 patients only. I've used LS and EMA and they were affordable. So of which I think only I think 2 of them did show chronic endometritis. Otherwise, all the others were normal.
That has always been a problem. You see something on histro, but when you send it for biopsy or IHC, nothing comes out, and it's very disheartening. So sometimes you just say, why should the patient spend so much money? Doxycycline for 2 weeks is much cheaper to give.
Yeah, giving doxycycline for 15 days. That is there. I don't know about the microbiota, even by doing that MR. Do you think that's really helpful?
But again, the tests are so expensive. How are you going to do that? So what I have started doing actually, and which I've been doing for a very long time in practice, is I always give lactobacillus. You know, Neutralin B has lactobacillus, and now Combinome is a preparation. So I always give that to the patients for a prolonged period of time so that their microbiota changes, because it's very difficult to pick up all these things.
Yeah.
I agree with madam. I also do the same thing. The issue with chronic endometriosis diagnosis is that the diagnostic criteria itself is so confusing as to how many plasma cells you need. So there are 4 different varieties of the diagnostic criteria, and none of them is clear as per the evidence base. So till we don't have a definite criteria, how are we going to get a diagnosis and treat it? So it all becomes empirical then.
I think one of the latest papers had a cutoff of 4 to 6 per high-power field for CD138, and below that would be fine, and above that, as it keeps going higher and higher, you would have more evidence of CE. But again, you know, these are things which are not available routinely to everybody, so difficult to do and practice.
So I think we are now closest panel of us. I hope all the delegates learned something from this panel and they understood it, but still we have a lot of questions which needs to be answered, like because of the heterogeneities of the studies which are available. So we are not able to pull up our data and make a proper guide what has to be done and what not has to be done. This gives you a basic idea what can be done and what should not be done. So with this, I thank you everybody.
Thank you, Sankalp, Madhuri, Swati for joining us. Thank you very much.
Thank you.
Thank you, Shalu. Thank you, madam.
Thank you. Thank you, Achal sir. Thank you, Simran.
Especially Sankalp, who was going somewhere and changed his program.
Thanks a lot for nice, wonderful panel discussion. Now we are moving for a session 1. To chair this, I would like Dr. Madhuri Patil ma'am for the use of PRP in reproductive medicine. What is the evidence? And the speaker is Dr.
I think you can just put Dr. Fadi's this thing. There's no need.
Dr. Madhuri Patil ma'am is going to chair this person. She is the clinical director of Dr. Patil Fertility and Endoscopy Clinic, Bangalore. And Dr. Fadi Sarara is the founder and medical director, Virginia Center for Reproductive Medicine from Washington, DC, USA.
Yeah, I think we can. I think his recorded lecture is there, no?
And I'd like to thank Dr. Nalini and good afternoon, everybody. I'm sorry I can't be with you in person, and I'd like to thank Dr. Nalini and Dr. Maduri for their kind introduction and for ferrying to sponsor this talk. My task is to talk about a very exciting new thing, which is PRP or platelet-rich plasma. And the title of my talk is Use of PRP in Reproductive Medicine, What is the Evidence? And this is a great, here we go. So what is PRP? As I said, it's platelet-rich plasma, and it has been shown to play a role in tissue regeneration, angiogenesis, cell migration, differentiation, and proliferation, which are mediated by numerous growth factors and cytokines that PRP release once activated. Specific growth factor and cytokines include transforming growth factor beta, fibroblast growth factor, insulin-like growth factors 1 and 2, VEGF, and epidermal growth factor. And PRP's initial introduction into medical practice was its role in tissue growth and repair in orthopedics and other specialty of medicine like cardiothoracic surgery, plastic surgery, dermatology, dentistry, and diabetic wound healing. It's even being used for hair regeneration. However, despite the use of PRP in various fields, there has been little high-quality evidence that demonstrates its efficacy. This is a slide from a recent paper that was published a few months back that shows the different growth factors that are secreted by platelets, like BMP, CCCLs, interleukin-8, PDGF, serotonin, TGF-beta-1, VEGF, and others. So really, there's a lot of growth factors that are secreted. And as we all know, whenever there's tissue healing, the first thing that gets to the tissue site is actually platelets and the release of all these growth factors. How is PRP made? So PRP is obtained through collection of an individual's whole blood via peripheral venipuncture that is then centrifuged to remove red blood cells from the sample. The purpose of this is to have a concentrated sample of platelets that contain 5 to 10-fold higher concentration of growth factors that get released by activated platelets. The general process of PRP preparation consists of collection of whole blood and initial centrifugation to separate and remove the red blood cells first from the sample. Then typically one additional centrifugation to concentrate the platelets, and then the addition of a platelet agonist to activate the sample. So preparation and standardization. This is one of the biggest issues. There are numerous methods of preparation for PRP from whole blood. You can do it through, in your office, or you can buy commercially available PRP kits, which are not cheap. With commercially available PRP kits, concentration and collection time vary greatly depending on the timing and relative centrifugal force, or RCF, meaning different concentration of platelets and leukocytes are obtained, which in turn impact the different types of growth factors in the sample. The lack of standardization in preparation method can potentially affect the outcomes and reproducibility of a study. So I recently published a review on PRP in Journal of Assisted Reproduction and Genetics. It is published online in March of 2021. What we did, we reviewed the whole literature looking at 3 specific things. The first one is public use of PRP in thin endometrium. The second one is the use of PRP in poor ovarian reserve or in menopausal women. And the third is in case of recurrent implantation failure. So I'm going to review every single one of them. I'm going to start with first PRP and thin lining, which is the first use of PRP in reproductive medicine. The first paper was by Chang in 2015, who analyzed 5 women who had previously undergone IVF without success with standard hormonal therapy and poor endometrial response. All received estradiol in increasing concentrations, starting with 6 milligrams per day and increase up to 12 milligrams per day if the endometrial lining responded poorly. Despite the increase in doses of estradiol in all of these 5 women, the endometrial lining remained less than 7 millimeters. So these women underwent a hysteroscopic lysis of adhesions, if any were found, and then intrauterine autologous PRP infusion. Like you're doing an IUI, use an IUI catheter, and you just put about 1 to 2 cc's of PRP into the endometrium. The endometrial lining was measured 72 hours after the PRP infusion. And if the lining was less than 7 millimeters, another PRP infusion was performed. 2 women received 1 infusion and 4 received 2 infusions. The endometrial thickness increased 48 to 72 hours after PRP infusion in all 5 women and reached 7 millimeters by the day of progesterone administration in all 5 women. All underwent embryo transfers, and of these, 2 had twin pregnancies and 3 had singleton pregnancies, but 1 of them had a miscarriage at 9 weeks, which was a Turner syndrome. And this is actually a slide from a clinic in Delhi that's advertising the use of PRP and infertility. But basically what you see in this is you get the PRP and you put it inside the uterus. Here they have a syringe, but you don't put it in a syringe. You basically use an IUI catheter to do this. It's like doing an IUI. And this is from my paper that was published in March of 2021. This is a table summarizing the data up to that point. Since then, there have been few more papers that have come out, but and out of these, there were 2 randomized controlled trials. And as you can see, the number of patients in all of these trials is really small. So the first one by Chang had 5 people, another one had 10. The first randomized controlled trial had 33 in each arm, and clearly showed an improvement in endometrial thickness from 6.09 millimeter up to 8.67 millimeter. The second randomized trial was published in 2019, which had 30 patients in each arm, and the lining increased from 4.92 millimeters to 7.21. And you had, with a pregnancy rate of 33.3% in that study. In the first randomized controlled study, the pregnancy rate was 32.5%. All of these women had had no transfer before or failed transfer because of thin lining. And you can see from the level of evidence, most were level 3 or 4, but the 2 randomized controlled trial were a level 2 because, and not a level 1 because the number of patients was rather small. What about the use of PRP in diminished ovarian reserve and menopause? Scott Sills was the first one who published on this in 2018. In his study, there were 4 patients with a history of premature ovarian premature ovarian insufficiency, undergoing intra-ovarian PRP, and then controlled ovarian stimulation. What he noticed in this study was the FSH level decreased and the AMH decreased, but the decrease in FSH was statistically significant, but not that of AMH. Following autologous PRP injection, all women had egg yields from up to 4 to 7 eggs per patient, and all of them saved embryos for a later transfer. One had a transfer that resulted in an ongoing pregnancy at 9 weeks of gestation. And this is a case report from a Greek group in Athens that was presented at ESHRE. It generated a lot of discussion at the 2018 meeting. So they had a patient who was 40 years old who had premature ovarian failure since age 35. Her FSH at baseline was 149 international unit per liter, and AMH was undetectable, 0.02 nanogram per milliliter. She had PRP injection, and 6 weeks after that, FSH and AMH were remeasured. The FSH dropped down to 27, but there's no estradiol level that was given in the paper. AMH level increased from 0.02 to 0.08. It's still undetectable. Nobody can say this is a success. And they did a natural IVF case with an embryo transfer, but the patient miscarried at 5 weeks of gestation from a spontaneous abortion. So this was, it was in the news as a success, and any one of us can know that this is not a success when you have a spontaneous abortion. If they had a live birth, you can say maybe there was an improvement, but in this case, clearly, at least in my opinion, this does not mean that PRP was of any value in this patient. And this table is a summary of all the published data up to when we wrote the paper. And you can see from the level of evidence, they were all 3 or 4. So most of these were case series or cohort with none of them having a single control group. Some of them showed improvements in AMH and FSH, but again, all of these are poor quality data. Most of them were actually cohort studies or case series. So at ASRM on October 18th, actually, the first day of the meeting, this oral presentation from this group in Istanbul, Turkey was presented, looking at the outcome of 510 women that used PRP. So the age range was from 30 to 46. All of them were Poseidon group 3 or 4, so really poor responders. All of them had AFCs less than 5 and AMH less than 1.2. And then PRP was injected into at least one ovary. Then they were brought back the second cycle after the PRP, and the AMH, AFC, and FSH were remeasured in these patients. And they were followed up to 4 consecutive cycles. Whenever there was at least one enteral follicle that was noted, then IVF was started on these women. What were the results? Out of the 510 patients with a mean age of 40.3 with a standard deviation of 4, the PRP resulted in higher AFC, higher AMH, lower FSH, and the higher number of M2 oocytes, 2PN embryos, cleavage, and blastocyst stage embryos compared to patients' prior cycles. There was no control. The patients served as their own control. After PRP injections, 22 women, or 4.3%, conceived spontaneously. 12 of those achieved sustained implantation or live birth, and then 92.9%, or 474 patients, underwent IVF, and 14 or 2.7% got the PRP and they were lost to follow-up. Among the women that did IVF, 50 or 10% of the total could not undergo oocyte retrieval due to stimulation failure or premature ovulation. 112 or 21.9% of the total did not have any embryos due to lack of oocytes or mature eggs at retrieval or fertilization or cleavage. 61.2% or 312 made embryos. Among the women who generated embryos and underwent FETs, 83 achieved a pregnancy and 16.2%, and 54 or 10.5% achieved a sustained implantation or live birth. So in conclusion, in the 510 women with premature ovarian, with poor ovarian reserve and mean age of 40.3, PRP injection in the ovary improved ovarian reserve parameters, led to a pregnancy rate of 20.5% and sustained implantation or live birth rate of 12.8%. However, nearly all of these pregnancies were in women who were younger than 38 years old. What about recurrent implantation failure and PRP use? The first report was published in Iran in 2017 by Farimani. In a 45-year-old woman who had a recurrent implantation failure, using her own eggs, she did 2 cycles with no pregnancy, not a big surprise at 45. But then she did donor oocyte and had multiple failed cycles, no unknown number of attempts. They did not put in the paper how many she has tried. She then received PRP 24 hours prior to frozen embryo transfer using 3 embryos from the donor cycle. And this resulted in a successful live birth. And this is this table from my paper, looking at the studies using PRP in recurrent implantation failure. And one of them was a randomized controlled trial using with 97 patients, and showed a clinical pregnancy rate of 44.9% compared to all prior failures. But most of these, again, as you can see from this slide, have used only very small number of patients, and only this one randomized controlled trial was published in this venue with recurrent implantation failure. So I accessed the clinicaltrials.gov website and looked at all the PRP studies that are currently in the database. And some of them, for example, this one using PRP on erectile dysfunction, obviously that does not relate to our field. Some of them are comparing GCSF and PRP for recurrent implantation failure. There's one that is ongoing in Abu Dhabi at this point, looking at PRP to restore ovarian function. We don't know much about this. There's 3 completed studies, but none of these have been published to date so that we can tell you whether that helped or not. The Innovium ovarian regeneration trial, that's a study that Scott Sills did. It finished in 2018, and as of now, the study has not been published. Stanford is doing a randomized trial on the use of PRP in women with recurrent implantation failure. And as far as I know, these are all euploid embryos that are used for this trial. And this study that's going on at EVRMA in New Jersey with Richard Scott, they have recruited about 50 patients so far. We probably will not get an answer for probably at least another year. But at least there's a lot of trials going on with using PRP. Now, I'm going to quote from this paper that I mentioned briefly earlier that was published in Human Reproduction. And the title of the paper, which I strongly recommend everybody reads it, is Intra-Ovarian Injection of PRP and Assisted Reproduction, Too Much Too Soon. And what the authors wrote, with ovarian PRP therapy in its infancy, there is poor standardization among research groups and clinics. However, this must soon be addressed to form a consensus as to the efficacy of this treatment. To assist this, we would propose that authors carrying out research in the area commit to reporting of key basic information regarding PRP, such as in platelet count, activation status, activating agent, if any, platelet function testing, origin of PRP, volume infused, anticoagulant used, clinical account of menstrual status based on AMH level, and a detailed reporting of the participants' fertility history. Additionally, while there are encouraging data supporting the notion that PRP treatment might have some future use in the ERT setting, it's paramount that we undertake robust and detailed basic studies to understand mechanism of action and to try to identify unintended outcomes. Before moving into whole animal studies, these precursors would be an important bedrock on which to carry out well-designed clinical trials, allowing us to investigate this new technology with all the rigor currently available. There are, at the time of this writing, 13 registered clinical trials investigating the effects of PRP on ovarian rejuvenation, either recruiting or underway. At least in clinicaltrials.gov in the US, not 13, but this is looking at worldwide data, probably looking also at the European registry. Strikingly, few of these trials describe the inclusion of appropriate PRP controls. It is only from well-controlled trials built on detailed mechanistic understanding that we can clarify the platelet-mediating effects of PRP therapy on ovarian rejuvenation and folliculogenesis. So in conclusion, although studies suggest that PRP has the potential to be promising in reproductive medicine through demonstration of endometrial regeneration, restoration of the menstrual cycle, improving folliculogenesis, increasing endometrial receptivity, and increasing clinical pregnancy and live birth rate, there is a need for prospective randomized controlled trials with large sample sizes. None of the papers have been published in premier journals, and most had low number of patients with few prospective randomized trials. And as I mentioned earlier, there are currently few ongoing randomized controlled trials worldwide evaluating the role of PRP in poor ovarian reserve, recurrent implantation failure, and thin endometrium in ART. It remains to be seen whether PRP is of any value in menopausal women, but the early results are discouraging. In addition, a standardized PRP preparation protocol is crucial to reproduce consistent and accurate results in all future studies. And my advice to everybody is, until definitive large randomized controlled trials are available, PRP use should be considered experimental. I know there are a lot of clinics in India that advertise the use of PRP, but everybody needs to discuss with their patients that this is an experimental procedure and that we definitely do not have a lot of answers to the questions we have, such as, if you want to use PRP, when do you do the IVF cycle? Do you wait a month? Do you wait 2? Do you wait 3 months? What's the volume you inject? I personally use about 3 cc's into each ovary if you're for cases of ovarian rejuvenation. But there's a lot of questions that we still don't have answers to. And with this, I thank you all for your attention, and I hope I will be with you in person soon in India. Thank you very much.
Thanks, Fadi, for that excellent lecture. But as he's not available for the Q&A.
Even we would like you to give some comments because he'll not be available for question answer session. So just, few comments.
Yeah, so I think all of us should realize that it is still experimental, and actually we are still not sure whether the bone marrow autologous stem cells are much better than PRP when we are talking about ovarian rejuvenation, because they do have the stem cells and probably therefore probably would give better results as compared to PRP. I think we have Dr. Firoza also here, so she's doing much more cases than what I have done. If she would like to give any comments.
Yeah, Madhuri, she is going to be speaking in the panel, so we'll do that at that
so then
time.
basically all of us, when we are doing, when we are using PRP, we need to counsel our patients that it is still experimental and the results may or may not be there. I think that's what I would like to say.
And maybe add a bit about the consent forms because that would be very, very important in this area.
So it is very important that we have a proper consent form which has to explain everything and the evidence about PRP, and we need to take a consent that it may or may not help. So taking a consent when we are using PRP, I think is very, very important, and probably documenting what you're doing is important, because unless we document and then we have a good number of cases, we really would not be able to say whether it's really helping or not. But just by saying colloquially, oh, I've done in this patient and it has helped, doesn't make a difference. So documentation and bringing the data together of everybody who's using it would give us a good number, and then that would help us in really coming to a conclusion whether PRP is really helpful either in thin endometrium, recurrent implantation failure, or for ovarian rejuvenation. But I think ovarian rejuvenation, I'm really not very sure whether it would really give much of results. But in thin endometrium, surely it is, in a few patients, it does give results and improves the endometrial thickness.
Thank you, Madhuri.
Yeah.
You'll have to go there, no? How can anybody hear you?
So I would like to thank Dr. Nalini for inviting me to chair this session. And I think we move on to the next session.
You're chairing the next one as well.
Yeah, I'm here only. Yeah. I finished my work for the day.
I would like, we will move for a second session. Can you, coffee has been served outside. If you can bring your coffee and we can move ahead for a second session.
Invite the chairpersons for the second.
You can call the chairpersons for this session.
For the second session, it is ovarian reactivation. For chairing this person, Dr. Simrandeep Kaur and Dr. Madhuri Patil Madam is invited. Dr. Madhuri Patil Madam, she is the clinical director of Dr.
You've already introduced now, you forget.
Dr. Patil Fertility and Endoscopy Clinic, Bangalore. She is an associate editor of Fertility and Sterility, an official publication of ASRM. She is chairperson of SIG.
And the president-elect.
She is a president-elect and founder member of a Fertility Preservation
That's
Society
it.
of India.
Okay, move on.
And Dr. Simrandeep Kaur, she is a scientific director and senior consultant of the Predictive Medicine Little Steps IVF, New Delhi.
I would like to invite Dr. Jasneet Kaur. She's consultant in fertility IVF at Milind Fertility Center, Chandigarh. She is the editorial member of the Oncofertility Journal and reviewer of the same. Okay, she's going to speak on reactivating ovarian function to autologous PRP infusion. Over to you, Dr. Jasneet.
Thank you so much for your kind introduction. My slides are not getting.
So today I'll be talking about activating, rather reactivating the ovarian function through autologous platelet-rich plasma. Now it was believed late back in the 19th century that all women are born with a fixed number of primordial follicles which are going to decline with age. Now this concept was further reaffirmed by the work done by Zuckerman in 1951. However, it was Jonathan L. Tilley who in 2004 proposed the presence of oogonial stem cells, thereby hinting at possibility of postnatal folliculogenesis. However, spontaneous activation of these oogonial stem cells is not yet believed to have occurred in vivo, and there lies the possible role of various ovarian rejuvenation techniques like PRP and stem cells. So today in my talk, I'll be talking about the role of PRP in ovarian reactivation. Now we've all understood what PRP is, and we understand now that platelets on activation are going to release a number of growth factors and chemokines, and the supraphysiological concentration of these growth factors and cell adhesion molecules is going to promote angiogenesis of the ovary, thereby increasing the blood supply to the immature follicular pool and to the oogonial stem cells via VEGF, PDGF, IL-8, and IGF-1. They are going to stimulate follicular development and help in recovering the ovarian microenvironment by increasing stromal cell proliferation, differentiation, and by attenuation of apoptosis. And also they are going to boost the stem cell migration and differentiation, which in turn is going to stimulate our oogonial stem cells and also might help in reawakening the resting dormant secondary follicles. So basically, platelets, when get activated, release a number of growth factors which enhance mitogenesis, angiogenesis, chemotaxis, which is either going to help convert these oogonial stem cells into primordial follicle, or they might help in rescuing these secondary follicles from undergoing atresia. Now, who should be offered ovarian reactivation? Well, patients with premature ovarian insufficiency, as defined by Esri, patients with a decreased ovarian reserve, preferably with previous failures, and perimenopausal and menopausal women for endocrine function or for fertility restoration. But what should be the ideal upper age limit to offer these techniques is something which we are not yet sure about. Now, we've discussed the technique of PRP preparation. It involves blood collection, separating, activating the platelets, and then intra-ovarian injection. But we must remember that there are a number of factors which can affect the response to PRP treatment, and also a number of factors which can influence the PRP yield. We also need to be mindful of the PRP kits that we are using, and ideally we should be using the FDA-approved kits. Now, the PRP kits that are commercially available are divided into low or high platelet concentration systems, but we must understand that high concentrations are not always beneficial, as a ceiling effect has been noted, which in fact might have an inhibitory effect. Therefore, we need more studies to understand the ideal platelet concentration and the activation technique which is going to work best on the ovarian niche. Now, coming on to the techniques of intra-ovarian insertion, it could be either transvaginal or laparoscopic guided, but counseling forms a very, very important role before we enroll the patients for this procedure. We need to explain to them the experimental nature of this technique, the meager evidence that we have because of the lack of well-controlled RCTs, an inadequate understanding of its mechanism of action at the cellular level, also the inadequacy of data regarding the long-term safety of the procedure as well as its effect on the neonate, and it being an invasive procedure. Therefore, consent taking becomes a very, very important part, and ideally a video as well as a written consent needs to be taken. All baseline investigations need to be done as we do in our OPO patients, including the ovarian reserve markers on day 2. Then a BSE preferably should be done. We should ideally give pre-op antibiotics, and then the way that we do in our pickup procedures. Under ultrasound guidance, once we fix the ovary, we put in our OPO or cyst aspiration needle into
ideally the subcortical region. And they've said that we can inject up to 1 to 4 ml of PRP, though we all know that it is easier said than done, especially in women with POI who've got atrophic ovaries. But they have stated that you can achieve this by either distension techniques or by creating multiple planes, or some authors have actually stimulated the ovaries, aspirated the follicles, and then injected PRP. But yes, there's a lot of controversy on what is the best technique. Then we check for bleeding and observe the patient for 2 to 4 hours. And some people have repeated it every month for up to 3 months. Now, when do we perform the IOPRP procedures? Well, authors have stated that in oligomenoric women, it should be done in the first 7 to 10 days of the menstrual cycle, while in amenorrheic women, it can be done randomly on any day. Now, what are the complications or the difficulties that are encountered? There could be difficulty in fixing the ovary, accessing the ovary, and even at times visualizing the ovary. There could be pain, which is though self-limiting. There could be bleeding either from the vagina or from the ovarian surface, or a possibility of injuring the internal iliac vessels. There could be infection, a possibility of bowel, bladder, anesthesia-related indications, complications, and maybe allergic reactions in case a PRP is not properly prepared. Then coming up to the follow-up of the patients, well, for that we need to understand this diagram. Now, for a follicle which is class 1, that is the preantral follicle, to reach the class 8 stage, which is the mature follicle, we require approximately 85 to 90 days. And so if we are postulating that the PRP is going to help rescue these secondary follicles, we need to monitor these patients intensively during the first 3 months. However, if we believe that PRP is going to act at the primordial follicular pool, then we need a prolonged follow-up, because the procedure, the time taken from the primordial follicle to a mature follicle is going to take around 365 days or 13 menstrual cycles, and therefore a prolonged follow-up of up to 1 year is ideally recommended, though how practical it is something which we need to point out. Now, when do we offer a laparoscopic approach for IOPRP? Well, in patients who've got very atrophic ovaries, or they are difficult to fix, or they are high up, or in case we are doing laparoscopy for some other indication, or it could merely be a clinician's choice and convenience, because some feel that injecting vagina via the transvaginal route, it may actually be coming out rather than going in. Now, coming on to the evidence behind PRP. Well, PRP for ovarian rejuvenation was first used by a group of Pantos et al., and they published their work in as a poster presentation in the ESHRE Congress in Helsinki in 2016. And what they did was that they took in 8 perimenopausal women and they injected PRP transvaginally. And interestingly, they found that all of them within 3 months had resumption of menstrual cycle. They even went ahead and did IVF for all these patients, and they did manage to retrieve around 2.5 follicles and around mean of 1.5 M2 oocytes. However, they did not have any embryos for in the embryo transfer. However, their work on ovarian rejuvenation, in fact, rejuvenated our interest in intra-ovarian PRP. Next, I'll be talking to you about this study published by Chatterjee and Selly et al. In Aging 2020. Now, this study is important because it's enrolled maximum number of POI patients. So they included 301 POI patients, which were defined according to the ESHRE criteria. They injected 2 to 4 ml of PRP in oligomenoric women in the first 10 days and randomly in amenorrheic women. They reassessed the patients 2 months post PRP and found a significant improvement in the AMH and AFC. However, they did not find any significant difference in the FSH value. Now, according to their study protocol, they wanted to wait for 2 months before starting controlled ovarian stimulation for IVF. And interestingly, they found that 7% of their patients spontaneously conceived during this 2-month waiting period. Now, they started course for majority of their patients in the 3rd month post PRP. However, in some of them, it was even started 6 months post PRP, and they started once they found an improvement in the ovarian reserve markers. Now, amongst the women in whom OPU was actually, who were enrolled for the IVF cycle, OPU could be performed in 64%. In rest of them, either they failed to recruit follicles or there was premature ovulation, and 40% of them ended up having cleavage stage embryos. The mean number of oocytes that they retrieved was 1.8. Now, the fresh and the fed clinical pregnancy rates were in the tune of 20 to 25%, while if they included the spontaneous pregnancies also, the overall pregnancy pregnancy rate was 11.5% in POI patients. So what they suggested was that they noted that women who do not have any antral follicle at the time of PRP were less likely to respond to treatment. Women in the lowest 25th centile for AMH and the highest 75th centile for FSH were also less likely to respond. And they stated that PRP actually helps activate the pre-existing preantral follicles or the early antral follicles, and the number of remaining follicles in the ovary of women with POI is likely going to determine the extent of their response. Now, next important study is the work done by Mello et al. Now, this study is important because it was the first prospective controlled, though it was a non-randomized comparative trial. So what they did was they enrolled 83 women, 46 were cases in whom IOPRP was done, and 37 were controls. And another different thing that they did was that they inserted PRP for 3 consecutive months. And the decision to undertake this was because they felt that antral follicle development takes approximately 90 to 120 days, and they postulated that repeating PRP would maximize the number of growing follicles which are going to get exposed to this intervention. So after 3 months, they found a significant difference in the AMH, AFC, and FSH values amongst the control and the cases. Also, they found more number of oocytes retrieved and also a better embryo quality in women who underwent PRP in comparison to controls. The cumulative pregnancy rate in the women who underwent PRP was 23.9% versus 5.4% amongst the control group. However, they did not find any difference in the live birth rate between the two groups. Now, the third important study I'd like to mention here is the work done by this Greek group, Sphagnitos et al. So basically, they conducted a pilot study in 4 groups, that is women with POR, POI, perimenopausal, and menopausal women. And they went ahead to do the IVF 3 months post-PRP injection. And they also found a significant improvement in the ovarian reserve markers, the number of days of stimulation, the number of M2s retrieved, though they did not find any difference in the embryo quality. And they overall had a pregnancy rate of 46.6% in POR women, while in POI women, they found that 60% restored their menstrual cycles and had a decrease in the FSH value, and the pregnancy rate was 10% in POI women. So summarizing these 3 studies, they've all noticed that the pregnancy rate in women with POI is in the region of 10 to 12%, while in POR women, it is around 23 to 40%. Now, is it possible that just mechanical disruption, thereby disrupting the hyposignaling pathway, could have its effect and not the PRP? Well, to answer this question, MD and et al. Did this study in white albino mice, right, in albino rats, and they first created a POI-like picture in them by giving them BCD for around 15 days intraperitoneally, and then they gave them PRP in both low and high doses, and they also had a sham injection group of normal saline. And interestingly, they found that women who did receive PRP had reduced follicular atresia and an improvement in the follicular quality in comparison to those who received normal saline, thereby suggesting that it is not the mechanical trauma, but the PRP which is doing the work. Now, next important study I'd like to mention is the work done by our own Indian group, where they injected a combination of stem cells with PRP in women belonging to Poseidon group 3 and 4, and they found that they had an improvement in the number of oocytes retrieved and also the embryo quality. Now, basically, how a combination of both of them is going to work is that stem cells via homing mechanism are going to reach the ovarian niche and secrete paracrine factors, which in turn is going to help in stromal cell proliferation, inhibition of apoptosis, and enhancing autologous ovarian vascularization, while PRP is going to attract the stem cells to the ovarian niche, thereby boosting their response, along with its own effect by the release of the products of the alpha granules. So is a combination of stem cells with PRP and a better understanding of the secretomes the way ahead is something which we need to think on. Then coming on to the pros and cons of PRP, we all understand that PRP is cost effective, it is autologous in nature and has an ease of isolation. But on the other hand, we are not sure of its efficacy. It's an invasive procedure. We are not sure of the legalities, and there's a lack of understanding of its actual mechanism of action. And the national guidelines for stem cell research say that PRP does not fall under the purview of their guidelines. Now, the contraindications for PRP is any active infection, thrombocytopenia, patients on antiplatelet medications, NSAIDs use. Now, patients who are on NSAIDs, they ideally need a 1-week washout period before we go ahead with the PRP procedure. Now, this was the study done by Atkinson et al., which was published in Human Reproduction this year, which stated intraovarian injection of PRP, is it too much too soon? Well, maybe yes, and we need more controlled RCTs with larger sample size. We need to have an idea about and prepare a customized PRP, which is going to work best for our ovarian niche by taking into consideration all these factors. Now, in the end, I'd like to mention this study, which was published in Human Reproduction way back in 1999, and they wanted to assess whether there's any intervention that could help improve the pregnancy rate in women with premature ovarian failure. And they stated that 30 to 40% of patients with POF, in fact, have primordial follicles, and around 10 to 15% of women with fluctuating POI and 5 to 10% of women with true POI are actually going to conceive without any intervention. So we in our studies have also noticed a pregnancy rate of around 10 to 15% maximum in women with POI, and therefore we need to ponder whether we are correct in attributing the success of these experimental treatments to the results that we are getting. Thank you so much.
Thank you, Dr. Jasneet, for the wonderful presentation. Anybody wants to ask anything?
On the intravariant PRP, and we'll ask all the questions at that time. Then let's go on to the next, and then.
I now invite Dr. Yodo, who's going to talk on reactivating ovarian function by ovarian fragmentation. He's the Associate Professor, Department of Obstetrics and Gynecology at Department of Frontier Medicine, Institute of Medical Science, and Mariana University School of Medicine, Kanagawa, Japan. He's done his MD from the same university and PhD also from the same university. He's a postgraduate medical and he's taken his postgraduate medical training from the same university as well as from the IVF Japan group. He has also been a postgraduate research trainee at the New York Medical College, New York, USA. He has vast experience in obstetrics and gynecology as well as fertility treatment, and he is member of several societies. Can we have his presentation?
Before I start, I would like to thank Dr. Nareen Mahajan, chairpersons Dr. Simram Deep, Ko and Dr. Nafefun Vercha for this opportunity. This is a great honor to present reactivating ovarian function by ovarian fragment to you today. Good morning, everyone. My name is Yodo Sugishita. I am Associate Professor at the Department of Frontier Medicine and the OBGYN at St. Marianna's School of Medicine from Japan. Today, I would like to talk about ovarian tissue cryopreservation, explain the difference between slow freezing and vitrification. Then, I will show the activation of ovarian function, specifically primordial follicle activation by physiologically signaling pathways and non-physiologically way, such as ovarian tissue fragmentation and transplantation. In 2004, the first rebirth baby was born after cryopreservation and the transplantation of the sold ovarian tissue by Professor Donay. This was a major breakthrough which paved the way for the future progress in this research field. The number of rebirths has kept accumulating since then. To date, over 130 babies have been born by ovarian tissue transplantation after cryopreservation and sowing overall. In Japan, our team have successfully delivered 3 rebirths after OTC by vitrification and the subsequent OTT. A recent paper published by Donay and the Dorman team this year. They mentioned that over 7,800 patients underwent ovarian tissue cryopreservation by slow freezing in 5 Europe countries. Over 200 babies were born. That means ovarian tissue cryopreservation is a popular method for fertility preservation now. In 2019, the American Society for Reproductive Medicine, ASRM, and in 2020, the European Society of Human Reproduction and Embryology, ESHRE, acknowledged OTC as an established fertility preserving technology for prepubertal cancer patients, and for patient whose cancer treatment cannot be postponed or do not have enough time to undergo ovarian stimulation. Next, I would like to explain the method for ovarian tissue cryopreservation through freezing and vitrification. There are 2 methods for ovarian tissue cryopreservation. One is the slow freezing method, and the other is the super rapid cooling method called vitrification. Currently, the standard freezing method for ovarian tissue cryopreservation is slow freezing. As you can see in this figure, in slow freezing method, the temperature is gradually decreased after exposure to low concentration of cryoprotectant. The ice seeding are formed at around -7 degrees. The external ice is effective in promoting slow dehydration in the tissue. The freezing rate has to be tightly and controlled, otherwise ice crystals may form and manage the tissues. Slow freezing requires expensive program freezers, needs a large amount of liquid nitrogen, take 2 to 3 hours to complete the freezing process, and it may damage the tissue due to ice crystal formation when the freezing rate is not controlled carefully. In the case of vitrification, the ovarian tissue is immersed in of cryoprotectant and rapidly cooled from the room temperature to -196 degrees in liquid nitrogen. The super rapid cooling and high CPA concentration prevent the formation of ice crystals and reduce the risk of mechanical injury to tissues. The results were published in 2013 and 15, and the last one has not reported yet. The clinical success is a result of various optimization in the vitrification and the transplantation process. As to complete the ovarian tissue is immersed in high concentration of cryoprotectant and rapidly cooled from the room temperature to minus 196 degrees in liquid nitrogen. The super rapid cooling and high CPA concentration prevent the formation of ice crystals and reduce the risk of mechanical injury to tissues. Vitrification is getting popular as an alternative to slow freezing because it has shown superior result for preservation of human oocyte and embryos. Vitrification has other advantages such as it is time-saving. Take about 30 minutes to implement. It needs a small amount of liquid nitrogen. No need for special or expensive equipment. It can be performed by the trained staff anywhere and anytime. However, many researchers are concerned about that high cryoprotectant used in vitrification may be toxic to the ovarian tissue. As I mentioned earlier, our team have successfully delivered 3 live births using vitrified warmed ovarian tissues. The results were published in 2013 and 15, and the last one has not reported yet. The clinical success is a result of various optimization in the vitrification and the transplantation process since 2006. We determined the favorable site for heterotopic transplantation of ovarian cortex and established the optimal cryoprotectant concentration. The ideal size of the ovarian tissue and developed a device with super heat conductivity called overcryo device type M. The ovarian tissue loaded in the open device comes in direct contact with liquid nitrogen. This poses a risk for potential contamination. To eliminate the risk of the concentration, we developed the cross device. In 2018, we reported that the resumption of hormonal cycles, follicle development, and oocyte retrieval from vitrified wormed ovarian tissue transplants in primate using the cross device. We showed that vitrification for ovarian tissue using a closed device has a potential of clinical application without the risk of contaminations. To address the concern about residual cryoprotectants, we conducted a study using bovine ovary tissues, cryopreserved by slow freezing and vitrification. After sewing, warming, we compared the residual cryoprotectant concentration of biogas chromatography. We demonstrated that the adverse effects of residual cryoprotectant toxicity could be reduced in tissue when implementing at least 60 minutes for diffusion and washing after sewing and warming. This washing did not affect the tissue integrity or significantly elevate the percentage of AC3 and gamma A2AX positive cells, indicating that tissue are safe and of good quality for transplantation. We published the result in Human Reproduction in 2021. In another study, we compared the follicle survival rate in these groups: slow freezing with open device, vitrification with open device, and vitrification with closed device. The result shows that there are no differences between the three methods in terms of primordial and primary follicle survival rate, but frozen ovary tissue in all groups showed lower number of primordial follicles compared to that in the fresh ovarian tissue. In the next section of the presentation, I would like to show the physiological or the organic activation of primordial follicles. The resumption of development from the dormant state is called primordial follicle activation, which is the first step of the follicle genesis. It is generally believed that the initial activation and development of primordial follicles through the primary and early secondary stages occurs independently of pituitary gonadotropins follicles, stimulating hormone, and luteinizing hormone control. And the researchers have shown that these two kinase pathways, PI3K, AKT, and mTOR signaling are essential in the regulation of early follicular development. The analysis of human oocyte transcriptomic and profiles revealed an increase the expression of both PI3K, AKT, and mTOR signaling pathways during the primordial to primary follicle transition. The proteomic analysis using mouse and ovaries at the different prepubertal stages also yield the similar trends. The expression of P10 in granular cells from human primordial follicles has been confirmed at the protein and the gene expression levels, and the AKT is expressed both in oocyte and granular cells of human follicles. For instance, treatment of ovarian fragments from the POI patient with P10 inhibiting and AKT activating drugs also promotes follicle growth, whereas mTORC1 inhibitor treatment partially limits follicle growth in vitro. Hyposignaling is a pathway which is thought to be active in ovarian stromal cells to control the size of the ovary as in other organs. Hyposignaling and consists of several negative growth regulators such as MST1-2, RAST, 1-2, YAP, and TAZ. When mechanical, structural, environmental, and changes occur, hyposignaling is disrupted. Primordial follicle activation is initiated. However, many questions remain unanswered regarding an involvement during physiological follicogenesis. This figure shows that the hypothesis regarding the role of HIPPO during in vivo and primordial follicular activation. A, the gradient of ovarian stiffness affects the activation of primordial follicles and regulates hyposignaling. The primordial follicles remain dormant in the lidded cortex. The softer modular disrupts hyposignaling and promotes growth. B, being close to blood vessels could unbalance hyposignaling and trigger the growth of follicles that are nearby. 3, larger follicles may suppress the growth of neighboring smaller follicles. D, lastly, structure changes in the ovary could disrupt local hyposignals and promotes the growth of follicles that are nearby. Autocrine and paracrine factors derived from the oocyte, its surrounding granular cells, adjacent and the stromal cells, neighboring follicles, and the local blood vessels contribute to control primordial follicle recruitment. The primordial to primary follicular transition is controlled by multiple factors, some intrinsic to the oocyte and others secreted as paracrine signals from the microenvironment. The action of activating factors are balanced by inhibitory factors. For example, the TGF-beta superfamily plays a role in the controlling primordial follicle recruitment. The diol, the glial cell, glial cell derives and neutrophic factors and on oocyte factors that acts to enhance the primordial to primary follicle transition. Activin and the inhibin are produced by the granulocyte cells from growing follicles, and studies have shown that they exert a negative feedback on primordial follicle recruitment. The steroid hormones such as estradiol and progesterone have also been correlated with inhibition of PFA. In the last section of today's presentation, I'd like and show the non-physical or the non-organic activation of primordial follicles. Ovarian tissue freezing transplantation is another way which influences the primordial follicle activation process. To prepare the ovarian tissue for cryopreservation, the medulla is trimmed away to leave only the cortical region about 1 to 2 millimeters thickness. Then the cortical ovarian tissue is cut to 10 by 10 millimeter size. The absence of growing follicles in the cortical region could disrupt the balance between the stimulatory and inhibitory signals in the graft, which in turn initiates the onset of the follicle activation. Comparison between cultured human ovarian slices, 1 to 2 millimeter in thickness, 5 to 8 millimeter in length, or cubes, 1 to 2 millimeter cubes, have revealed that initial follicular recruitment occurred earlier in cubed than in sliced tissue. We found that fragmentation mirroring ovaries promoted the actin polymerization and disrupted ovarian HIPO signaling, leading to increased expression of downstream growth factors, promotion of the follicle growth, and the generation of mature oocyte. In the clinical study published by Professor Kawamura, the one-step and drug-free procedure involved removing the ovarian fragment laparoscopically, dissecting the ovarian cortex into the small cubes, then immediately retransplantation to the patient. 2 babies were born by this method in POI patient. Thank you very much for your attention today. These are our reproduction team. Thank you very much again.
Thank you, Yodo, for that excellent lecture. We have him here for the Q&A session. So we could take questions from faculty as well as from our delegates for both Dr. Yodo as well as for...
Okay, let me ask. Yeah.
Ma'am, I like to ask,
Achha.
just need, what is the role of
Good morning, Dr. Yodo. Thank you very much for this beautiful presentation and thank you for making time to be here. What I wanted to know is there are a number of groups, especially Cesar Diaz and all, from whom I actually went and saw his this in vitro activation, or rather in, where they just do the mincing of the ovarian cortex and then putting it back without activation or freezing. So in do you also do that? Is there a comparison between the one which you do cryopreserved and one which you do direct without cryopreservation and activation?
Yes. And yeah, Dr. Narini, hello.
Hi.
And yeah,
And maybe you know, and we already tried to the transplant and just in the very small cube transplantation, and at the other side and the regular seed transplantation. But then these are about small amount of data from our university. So and now is there are no significant. But the Professor Kawamura and he was at St. Mariana and maybe some years ago, and he moved to another university to get just professors. And so he continued to just collect the data, and finally he published in the last year. So and he mentioned already, and just and we don't we do not have to use just some chemicals to induce the follicle activation. And he mentioned already, and just and we have to like chop the frozen so the ovary. That's a very important. If we cannot we cannot make a very small cube, and the tissue cannot work.
Because when you're doing the freezing and activation and then putting it back, there are two invasive procedures. One to take out the cortex and one to put it back. So in his other series, is he doing it at the same sitting or he's still freezing and putting?
We usually use just after the frozen and the thawed tissues.
Okay, okay. Because with Dr. Caesar Diaz, they make the tissue, and one case I also did, he made the tissue and then just put it back directly at the same time so that the patient didn't have to go through a subsequent surgery.
Yeah, because in just some some people already mentioned that if we freeze just in the ovary and the follicles very and decreases and amount, you know. But Dr. Kamra already tried, and he chooses just POI patient and for fresh ovary, and now he are trying to freeze the ovary and sew the ovary and chop the frozen ovary now. But then he mentioned already, and we should just cut a very small cube for transplantation.
But is it not better that we put in the fresh tissue, because your freezing and thawing is again going to reduce the number of follicles?
Yeah. Yes. Yeah.
Anybody else has any questions?
Freezing would rather hamper it. It is said that you put it fresh, and then after 4 days of stopping the hormonal treatment, you start the stimulation, and that is the time the hyposignaling will give the best effect. That is what Claus Anderson has said. So that's what I wanted to ask. Why freeze it and then do it in a second setting when the hyposignaling will have the maximum effect immediately? Is there any experience or answer to that?
Yeah, and we usually use just a hormone therapy before,
Yes.
after transplantation.
Start it
Usually-
before transplantation, stop it 1 day prior to the surgery. 4 days later or 5 days later, you start the stimulation so that the hyposignaling effect would be the maximum on the follicles at that time.
Yeah,
So I think the question, is that how long after, you disrupt the ovarian cortex and put it back, would the effect of that show up in the follicles? So what is the time frame?
We usually use just the hormone therapy and in 2 weeks after transplantation operation.
Because I think earlier than that, follicles may not regenerate that fast. That's my feeling. I don't know for certain. Naina, do you have any experience? I think you are doing in vitro activation in patients there.
Yeah, in our experience, we have done so far about 10 cases. Immediate response was not good, but we waited for 1 or 2 weeks, what he said, 2 weeks later, 3 weeks later. And that is the time we could see 1 or 2 odd follicles growing with the hormone therapy. 4 or 5 days is too less. That's what Dr. Mahajan says, and that's what I agree.
So because I also feel that it's too short, and I have actually monitored one of the patients on whom you did this, on one side PRP and one side in vitro activation, and actually I think on the side that she had the PRP, she had better follicular growth than on the in vitro activation. But then she was an older patient also, so age also affects all these things. And in
Dr.
terms
Mahajan,
of
we have been comparing both PRP and OTA on either side, and ovarian tissue activation. When the volume of the ovary is good, the cortex, the results are better. In fact, the quality of the egg and the embryo is better with OTA than with PRP. That is our experience. We have done just 12 cases, but that is what we feel right now. And we have a patient conceived, aborted, again conceived naturally with a corpus luteum on the right side where we had done the OTA.
So I actually, when I did the procedure, the ovary of that, one of the ovaries was so small, I couldn't put the ovary tissue back there, so put it in the broad ligament. And the follicular activation and development in that was very, very exciting, because you could see it very, very clearly, absolutely apart from the ovary. So I think age of the patient probably in the end will matter. What do you say, Dr. Yoru?
Yeah. So but she said already, and so and I also agree. And so if you wanted to just proceed just a follicle activation and as soon as possible, and after transplantation, and we have to use some medication and especially hormone therapy, and in some weeks. But we are not sure that when we should do. But we usually understood just prescribe some hormone medication in 1 month. And we usually check just and every 2 weeks after transplantation, and around the 50% of the patient, and we can see just in the very small follicles. But that means and just frozen method is nice, because if the frozen and the method is not good, and we cannot see at least in the 3 or 6 months.
I think Dr. Simran wants to ask Dr. Jasneet a question. So thank you, Yoru. Thank you very much for joining in, and on a Sunday. Thanks a lot for your lecture. Thank you.
Dr. Jasneet, I would like to ask, what is the evidence of putting intra-ovarian PRP in endometriosis?
पैनल डिस्कशन अब क्या है कि बहुत कुछ मतलब थोड़ा कॉम्प्लिकेशन हो रहा है.
There might be a possibility that we might activate the endometrioma because of the growth factors that we are releasing. And also some people say the chances of infection might be on the higher side. So maybe if they've got endometrioma on one side, we can do it on the other side, but doing it on the same side as that of the endometrioma is something which we're not sure of as yet.
That will be only if you have a low ovarian reserve associated with endometrioma.
Yes, ma'am.
Yes, yeah. And that is if she has undergone repeated surgeries. Otherwise, usually, if the patient is young and has got an endometrioma, then and she normally would have a good ovarian reserve. So therefore, even the newer guidelines, what they say that probably if you can access the follicles, it's best that you don't touch the endometrioma. That's what.
In another ovary, but we can go ahead with intra-ovarian PRP.
No, not PRP is not necessary unless the ovarian reserve is really less.
Yes, in PUR. Yes, endometriosis along with PUR.
This happens only when the patient has undergone repeated surgeries.
Yes, ma'am. So in that case, I was just wanting to know, because studies are still controversial, whether we should go ahead or we shouldn't go ahead.
Yeah, and therefore, basically, even the newer guidelines and the newer studies say that if you can access the follicles, it's best not to subject the patient to surgery. So you do your IVF first, and then probably the surgery can be done if the patient is symptomatic. So in these cases, what they do is they do the IVF, they freeze the embryos, and then probably they do the surgery, and then later on they do an embryo transfer. So we thank both the speakers, Dr. Jasneet as well as Professor Yodo, for excellent talks on PRP and ovarian tissue activation. And now we move on to the third
The next session. Thank you.
She had given a very elaborate introduction and scientific knowledge about the reactivating ovarian function. Now moving ahead for a session 3, it's recent advances. I call Dr. Tanya Bakshi ma'am and to Dr. Sankalp Singh to chair this session. Dr. Tanya Bakshi ma'am, she is a principal consultant IVF in reproductive medicine and oncofertility Max Super Specialty Hospital, New Delhi. Dr. Sankalp Singh, he is presently working as a director of Yami Fertility in the Madhya Pradesh.
Good morning. And first of all, thank you, Nalini ma'am and Shalu, for such a wonderful workshop on something that's so topical and will be the future. It really is my privilege and honor to introduce Dr. Naina ma'am. She is one of the most glamorous and pioneer that we have in the field of regenerative medicine. And I know my journey for the first hysteroscopic PRP that I did in Max was all thanks to ma'am and her guidance. Ma'am is the medical director of Akanksha Hospital and Research Center in Anand of Gujarat. She has pioneered in the field of IVF and surrogacy in India and has more than 1,649 surrogate babies born till date. Ma'am has authored many publications and has numerous awards, and she's the president of the Obs and Gynae Society of Gujarat. Ma'am's case report in the international journal SERM credits the first case of a live-born baby after bone marrow-derived stem cell therapy. Ma'am is also a reviewer of multiple journals, JSRS, JRHM, JARG, Human Fertility, and TNF Frontline. So without ado, ma'am, the floor is yours, and we are eagerly awaiting to hear you once again.
Thank you, Tanya, for that introduction. And first of all, I would like to thank the Fertivision Organizing Society chairpersons, secretary, and Dr. Nalini Mahajan for having me over here for this wonderful session on regenerative medicine. So today, my topic is use of autologous bone marrow stem cells in endometrial regeneration. 1 minute. Yes. So why do we need endometrial regeneration? Thin endometrium is an enigma, and a receptive endometrium, which is a very essential part for the embryo to implant. Inadequate endometrial growth is associated with lower pregnancy and miscarriage. And there are numerous reasons for this: dilatation and curettage, repeated surgical trauma, endometritis, genital tuberculosis, a big thing for our country, septic abortions, fibroid surgeries, radiations, and chemotherapy. So there are various treatments that have been coming up for thin endometrium, from hysteroscopic adhesiolysis being one of the most treatment that is being done with hormonal manipulation, improving the endometrial perfusion, and now the newer modalities in the form of regenerative medicine. And that is stem cells, what I'm going to talk about for endometrial regeneration. Stem cells are undifferentiated cells with capacity to differentiate and multiply into numerous cell types. And they were identified in the small intestine and colon using the marker gene LGR5 through lineage tracing experiments. You have totipotent cells from embryonic stem cells, pluripotent cells, multipotent is the adult stem cells, and you also have the unipotent stem cells. The embryonic stem cells derived from the inner cell mass. The adult stem cells, which are multipotent, derived from bone marrow, adipose tissues, umbilical cord, dental pulp, peripheral blood. We have also got it from human milk. And induced pluripotent stem cells, which are genetically modified to become pluripotent. So these are the various sources. And the administration of stem cell could be directly to the targeted area, or you can systematically inject it. You can also differentiate it into something like pancreatic islet cells for diabetic patients. But this is important, stimulation of endogenous cells to facilitate repair, which can be accomplished by administration of appropriate growth factors and drugs that amplify the number of endogenous stem cell progenitor cells and or direct them to differentiate into desired cell types. If you look at the physiology of endometrium, you have the basal layer, you have the functional layer. The basal layer remains intact during menstrual cycle and it consists of large spiral arterioles. Whereas the functional layer undergoes number of changes. It is supplied by tiny vascular network, grows during the cycle, and during menstruation, it is completely discarded. But following ovulation, there is a constriction of the spiral arterioles, which will reduce the blood flow to the functional layer capillary network. And as a result, when the embryo is implanting, there is reduction in the oxygen tension in the functional layer, which will improve and facilitate implantation. Whereas the basal layer, which is very close to myometrium, does not get affected by the cyclic hormone changes. And in a thin endometrium, the functional layer is very small, so the embryo gets implanted near the basal layer, which has huge spiral arterioles with copious blood flow, which leads to reactive oxygen species production and interrupts with embryo implantation and development. So why and how? This is what is seen. We want something like this and not like this. This is the functional basal layer myometrium, and these are the spiral arterioles, and these are the endometrial niche epithelial and stromal SP cells. So what is this concept of endometrial niche? It is an anatomically defined compartment in which stem cells reside and are able to renew or remain undifferentiated. And this niche has a spatial dynamic microenvironment in which stem cells interact with differentiated cells, secreted factors, and or components of the cellular matrix. Now, the presence of stem cells in the endometrium was first evidenced in 2004 by two different research groups, both reporting existence of clonogenic endometrial cells, epithelial and stromal, with high proliferative potential. And the important thing is the specific role of bone marrow-derived stem cells in the regeneration of this tissue. And the gold standard technique to demonstrate self-renewal are the demonstration of clonogenity and long-term culturing capacity. The other common approaches include cell surface markers in other stem cells, immunoglobulins or clusters. Now, endogenous endometrial stem cells are also there, and these endometrial stromal cells, if we look, the mesenchymal stem cell CD70, 390, 105, and stromal cell 1, but they lack the fibroblast, hemopoietic, and other well-described markers. There is also EE, the endometrial epithelial cell population, which is present in the epithelial cell marker of CD9. And endometrial stem cells CD31, 34 have been detected among the stromal factors. So if we see the source of stem cells, menstrual blood, very good, endometrium, but patients of thin endometrium already have very less endometrium to regenerate this and very less menstrual fluid for this. But bone marrow, they can have healthy bone marrow in young patients, and that can help into differentiation of endometrial stem cells and epithelial cells and even leukocytes. Now the LGR5, studies have shown that LGR5 cells from human endometrium have the capacity to activate the stem cell niche. And Cervello et al. Extracted these cells from the human endometrium and used it for subrenal transplantation and found that both of these are good for endometrial cells to promote endometrial cell-like regeneration. And even the microphage-like cells are possibly recruited from bone marrow to activate the endometrial stem cell niche. So now we are learning what are stem cells, how the bone marrow-derived stem cells could be the best, and then few more things, autologous and fresh. So increasing evidence is showing that endometrial regeneration, at least partly on recruitment and engraftment of bone marrow-derived cells and their subsequent differentiation into non-hemopoietic endometrial cells is there. They will act in the cell, bone marrow-derived concentrate will act
in combination and have the capacity to integrate and into damaged tissues and also transdifferentiate into host tissues. Now, whether we should be using fresh or culture. So this is an interesting article just published in 2021, when this group has found that freshly isolated mesenchymal cells and endothelial progenitor cells together with BMDC hypoblast-like stem cells induce the greatest degree of regeneration. So we don't need to culture these cells, because if we culture the mesenchymal cells, then these may have an opposite effect on endometrial regeneration, and the different behavior between the freshly isolated mesenchymal cells and cultured mesenchymal cells can be explained by the loss of surface receptors CXCR4 during cell culture, which is very important for the homing of the cells to damaged tissues. And we want these cells to home into the damaged tissues for it to regenerate. One more evidence in murine models where it has shown that endometrial tissue in murine model of endometrial atrophy, when they were treated with BMSC, there was significant thickening, there was increased level of anti-inflammatory cytokines and decreased pro-inflammatory cytokines. Also, along with it, acupuncture and collagen scaffolds can help it regenerate better. Now, the paracrine actions of stem cells, main finding in the endometrium. When when you inject the stem cells, they engraft into the spiral arterioles of the endometrium, where the stem cell niche is thought to be located. And this free finding reinforces the existence of this stem cell niche and paracrine effect that the endogenous cell is exert to attract the therapy stem cells in this case to directly over the niche and promote tissue regeneration. Most explored sources are umbilical cord and amniotic fluid for endometrial pathologies. Both this can be used allogenic. Bone marrow and adipose tissue are autologous. So when you are using autologous bone marrow derived concentration, complications such as graft versus host disease does not apply. Only disadvantages in some patients, there will be insufficient number. I had one patient where there was a dry tap. So you cannot do that. And because it is autologous, because there is no graft versus host disease, this explains why most published work in this field, most of them in the form of either pilot studies or case reports, what is that we have done, directly tried the therapy in humans. Now, which stem cells to use? Non-hemopoietic, hemopoietic. So we know that some studies have used non-hemopoietic. Some studies have used only the hemopoietic CD133, but many studies report the use of whole blood bone marrow stem cell fractions, and that is what we used in our case report and pilot study. So this is one article, clinical efficacy of stem cell based therapy in the Asherman syndrome. And there are a number of articles, including two from India, where they've shown that direct intrauterine installation of the cell, bone marrow derived cells into the uterus would give a better outcome in the form of menstrual duration, pregnancy, and endometrial thickness. This is another update of cellular therapies where they've found that any reason, it could be idiopathic miscarriage, iatrogenic, or infection, genital endometritis, genital tuberculosis, there will be unbalanced breakdown, repair, defective endometrial healing, adhesions. First step is hysteroscopy, hormonal therapy, nothing happens, cell therapy by intrauterine infusion, transmyometrial injection, hysteroscopic injection, and intraarterial catheterization. And clinical trials piloting cell therapy have used the stromal cell and angiogenesis promoting therapy, and have used even umbilical cord mesenchymal stem cells where they have seen important results. Angiogenesis promoting will mainly use CD133 from the peripheral blood. So what we decided at our center, that we will take the bone marrow, derive the concentrate manually, separating intrauterine instillation. One case we got a result. Then we were encouraged to do the subendometrial hysteroscopic bone marrow derived cells into the just endometrial myometrial junction. About 2.8 ml is taken with the egg retrieval needle in 4 walls after removing the adhesions, the anterior, posterior, and 2 lateral. About 0.7 to 0.8 ml is injected. But finally, we came with, in spite of not getting good results in some of the patients, we thought of bone marrow derived cell instillation directly by interventional radiology into uterine artery spiral arterioles. The proof of concept that we had was that fresh autologous is good, and endometrial niche is located in the spiral arterioles surrounding it. Bone marrow has many advantages in stem cell amplification than uterine derived cells, and recruitment of bone marrow to the endometrium was higher when this is an experiment in the animals were injected intravenously via the tail compared with intrauterine. So more amplification of stem cell and regeneration of endometrium when it is injected via the tail rather than the intrauterine injection. And to inject BMDC directly into the spiral arterioles, they will come out into the surrounding endometrial niche, home in there, and then regenerate the endometrium. So this was our first case report, a 26-year-old, 3 failed cycle, almost amenorrheic, multiple hysteroscopies done, treatment with us 2017, 2018, no lining development. They stopped the treatment with us. In 2019, January 16, we called her for this first experimental study where we wanted to start and inject her bone marrow derived cells. So we took the permission from the ethics committee, and then we have the certificate from the health research and a certificate of good laboratory practice. This is the OT where we take the stem cells. This is the stem cell lab, and this is the cath lab, biosafety, and the fluorescent microscope. Pre-procedure audiovisual consent was taken. Patient was admitted 1 hour before. IV antibiotic, 2 to 4 liter of oxygen was given for 30 minutes, vitamin C 150, and glutathione was injected in 100 ml NS. And then the patient was taken for bone marrow aspiration from the iliac crest, which is done under anesthesia because we don't want the patient to be scared or make it painful procedure. And about 80 ml is the ideal, but younger patient, even 40 to 60 ml can give a good harvest of the mesenchymal stem cells. So what we do initially is we do an ultrasound on that day, then we take the patient for this procedure, same sitting, we again do a hysteroscopy to check what the cavity looks like. And once this bone marrow is collected, it is sent to the lab where the scientist will start, our PhD scientist will start the preparation of the bone marrow concentrate in a typical manner. This is the lab, and it will be put on the ficol, and again it will be cell counting. But here in about 1 hour and 25 minutes, there are special machines also available, the Sepex and the Angel, but we use the manual method. And these harvest, when it is done in about 1 hour 25 minutes, microbial culture is sent, though we don't get the report immediately, but infectious disease test is immediately confirmed, and these are the typical cells that we get. And after the procedure is done, we use this technique to do the markers, and mainly we have found 34, 73, 90, 105, and even 133. All these cells are then injected. This therapy will target the endometrial niche, and another important, because it is located just around the spiral arterioles, and there is no need to separate CD133 and do an elaborate process. A simple process of bone marrow aspiration, collecting the cells, and then putting it inside is good enough. So this is the procedure in the cath lab. We have our own cath lab. So there we take the patient, the femoral artery is punctured with the needle, the guide wire is passed, and then another wire is passed, and then finally the microangiocatheters, they go to the opposite side of the iliac artery in this. You can see, and both the femorals are punctured, and once they go to the opposite side, they enter the spiral arterioles with microangiocatheter, and then they inject about 1 to 1.5 ml of bone marrow derived concentrate in both the uterine artery spiral arterioles. And we make it a point that one of the doctors is always present for the procedure, because initially first stage we had to do a Foley's catheter to identify the uterine, but now they can do it with a dye test easily and identify where the internal os is and how the uterine is identified by the interventional radiologist. And this is how the patient does not need anesthesia at this time. It's only the local anesthesia that is given, and the patient can virtually see that where, and even we can see sometimes there is a blind uterine artery, it is severely stenosed and we cannot inject. So this is the procedure, how it is being done. And finally, when it is injected, you can see that through the spiral arterioles, the jet comes out, and which is located which spreads around the spiral arterioles surrounding, where the endometrial niche is expected to be there. See the jet that's coming out. Yes. So then she was then treated for hormonal therapy. Her menstrual flow next month, immediately it increased. And this was done in January. We decided to do a transfer when 7 mm lining was done. You can see this lining beautifully done. And she delivered a healthy baby boy. So this first case report was accepted by clinical and experimental reproductive medicine, wherein they said that this is a therapy for Asherman's or atrophic. This patient was a tuberculosis, genital tuberculosis patient, and this has helped. So after that, we started doing, and totally 12 cases pilot study we have done. The second case, she was from Bangalore, but husband worked in Anand. She got stuck in Anand and she could not go during COVID. She approached us that my embryos are frozen. I cannot undergo transfer because of thin lining. We explained this procedure. We did this procedure on her, and in April 2020, she had a good flow. July, she could travel back to Bangalore, where the doctor was very happy with the lining, did the transfer.
I don't know.
And these two
Naina ma'am, please unmute. We can't hear you. Yeah.
Yeah, now, right. Then, so we decided to do a pilot study in 12 patients, which we have done so far. And this is again accepted in the Journal of Regenerative Medicine. This issue, it will be coming out, wherein all these 12 patients we have highlighted the history from thin endometrium, reason being abdominal tuberculosis, genital DNC, myomectomy, postmenopausal Asherman syndrome, fibroids. And the age group varied from 47 to 27. They had scanty or just spotting hypomenorrhea, amenorrhea. The maximum thickness pre-procedure was this much. After hysteroscopy also, we could not get it. And then with the bone marrow derived stem cells, when we did the cath lab procedure, we could find that in some, the uterine artery was very good and the outcome was very good. But in some, the uterine artery was finally stenosed, or it was very difficult to negotiate and pass the microangiocatheters, and we saw that the outcome was not there. So out of these 12 where we have undergone the transfers, in 6 patients, 3 delivered, 1 has ongoing pregnancy, 2 have negative results, but they are waiting for a second transfer, and 6 patients treatment is still pending. 1 has already opted for surrogacy and has successfully surrogate got pregnant. So this is the total study. There was a similar study, but differently done, autologous cell therapy from bone marrow derived stem cells for reproductive Asherman syndrome by Carlos Simon group. And there they also did a study of 18 patients with 17 positive pregnancies, and 3 on the whole, they suggested that the CD133 BMDC, but this is a very elaborate procedure. You collect blood 3 times, you have to just mobilize the bone marrow stem cells peripherally and take blood 3 times, about 300 ml, do apheresis, which is again an expensive treatment. So this bone marrow derived could be a cheaper treatment for the patient. Now there are tissue engineerings also available. The collagen scaffolds are coming up, which will not only maintain the stemness of transplanted BMDC in the injured endometrium, but also effectively promote regeneration of the damaged endometrium with increasing thickness and reducing the scar tissue. Hydrogels are also available now for the treatment, still experimental. Treating patient with stem cell in India, Dr. Madhuri will give details, but just what we follow are the guidelines. Audiovisual consent is a must. There is a notification you cannot use stem cells, but if you are using autologous, where the individual's own bone marrow cells are collected and minimally treated, we actually don't treat it, we just separate it and infuse it back immediately. These guidelines will not affect us. So that is the reason we started this. Future perspective could be phenotyping and functional characterization. Furthermore, recognizing more angiogenic properties of BMNCs, including CD133 cell population, And also the primary effect of cell therapy is through the release of paracrine factors rather than cell engraftment. So what is actually acting? It is the cells, they go home in and regenerate, and the paracrine factors also come in. And now they say even the exomes of the bone marrow are very useful in the regenerative medicine. To conclude, I will say that stem cells are key to the normal functionality of the endometrium, but it is necessary that complete understanding of their activity is essential in management of endometrial pathologies, and we can use even for cancer patients, endometrial cancer patients and radiation patients. The presence of endogenous stem cells in the endometrium has been widely accepted and described now. Further studies with large sample size are needed to establish more solid evidence for administering this therapy in clinic. Well, thanks a lot for giving me this opportunity. And again, greetings from Akanksha as well as Zivia IVF. Thank you.
Thank you, ma'am. It was indeed fantastic. And I think there are loads of congratulatory messages from Firoza ma'am, Dr. Sonia Malik, and obviously Nalini ma'am. Really, it's such a proud moment to see such fantastic work coming from back home. And you inspire all of us. Thank you so much, ma'am.
Thank you.
So moving on to our next lecture, we have another pioneer in the field, Dr. Professor Neeta Singh. Ma'am is the professor, Division of Reproductive Medicine, Department of Obs and Gynae at AIMS. Ma'am is an international fellow in reproductive medicine from UCL London. She's also been chair of experts at the National Board, member for the task force for the ART regulation at ICMR. Ma'am is also visiting professor at AIMS Patna Rishikesh IGI-MS, and she was a part of the team which produced the first IVF baby of AIMS. Ma'am has numerous awards and fellowships, some of which include the Foxy Imagic Science Award, Foxy Young Scientist Award, and she has more than 160 papers in indexed peer-reviewed journals and more than 30 chapters in different textbooks. So without further ado, I have this great privilege of calling upon ma'am, who will further elaborate the use of autologous bone marrow stem cells in ovarian rejuvenation. Floor is yours, ma'am. Hello, Neeta ma'am, please share your screen. Ma'am, आप mute पे है? We can't see.
Hello, ma'am. I'm just coming. I was trying to sync my computer. Just apology, ma'am, for 1 minute.
Ma'am, could you please close one device? I think you have two devices on. There's a lot of echo.
बेटा 1 मिनट आओ, अभी हो नहीं रहा है.
More congratulatory messages. Naina ma'am, Madhuri ma'am also sends a very big applause. Neeta ma'am, you're mute. Please unmute.
Yes. Can you see my slides, Tanya?
Yes, ma'am.
Oh. So at the outset, it's my privilege and thanks to Nalini ma'am and the entire team of Fertivision for doing such a wonderful workshop, which is the need of the hour. And after having listened to such a wonderful presentation by Dr. Naina Patel, it is absolutely futile that my talk I'm going to speak on. She has done wonderful work because we haven't done injections into the spiral arteries. I did some work on endometrial regeneration, and I did publish that work, but that was in the local injection of the stem cells and bone marrow derived. So the background talk, why all of us are worried and we are talking about regenerative medicine, we can see that the infertility burden of infertility is increasing day by day. And you will see that this is the end of high fertility. I will give you the data from the latest NFHS, which will show you this used to be the old picture. And end of high fertility is in sight and arriving soon. And replacement fertility rate and the birth per woman in most of the industrialized country has gone below the replacement level. And the global fertility trends, if you will look at that, this slide, which was recently shown in the Bloomberg annual journal, that the global fertility crash. And you can see that the world average, and where do we stand? The India world average is 2.4 TFR versus India, it is 2.1. And I will show you the latest NFHS data that you will see that the total fertility rate in the 1921 NFHS 5, you can see that it is 2. And it is really, really alarming because for replacement, we need 2.2. And the projected urban TFR is 1.6. It is, I think all of us haven't seen the figures. It is really, really alarming what we are going to face tomorrow. And the TFR, not only in urban, the rural area has also gone 2.1, for which we need replacement fertility, it should be 2.2. And if you look at this slide, what is going to happen in 2100, the projected figures of global fertility and the India, you will see from where India is going much, much below the global standards. And what I showed you, the end of high fertility for India, we are going for the lowest fertility rate. The projected TFR for India in 2100 is 1.3. So as we all know that the reproductive lifespan of a woman is very limited. The reproductive window is very, very limited. And more so if we look at the Asian women or the Indian women, which makes more prone for decline in fertility, is that you've seen from the recent publication that the ethnic differences in ovarian aging between Caucasian and Indian women. So our girls and women who are making their careers, when they compare themselves that, okay, my friend who's in US, she's 40 years, she still can have a baby, but she cannot have the same fertility applicable to her, because ovaries from Indian women seems to age at an earlier age, and it is 6-year difference than the Caucasian. And therefore, we have to prepare or educate our young population that we cannot have same fertility as the Caucasians because of the ethnic variation. And the high rates of genital tuberculosis, there are publications by Indian women, besides the ethnicity, are also prone for diseases like genital tuberculosis, which compromises the ovarian reserve further. So what socioeconomic factors are contributing to infertility? We all know the empowerment of women, women's education. Choice of having a child is a question of opportunity cost, and education changes them. It is because the opportunity cost of better educated women are higher, and that they are less likely to want to have a large number of family. And women who are better educated have to turn down more opportunities than women who are less well educated. So the effect of age on the ovarian reserve, we all know that, but just to recapitulate that, we know that at the age of 37, about 27,000 follicles are there in our ovaries, and at the menopause, we still have 1,000 follicles which are lying in the dormant condition. And we are looking at this window that can we expand. So there is a progressive decline in the oocyte quality and the quantity with age. You can see that the optimal fertility has been described between 25 to 30. And at the present time, I don't see most of the patients living in the urban area, they don't want to have a baby before 30. And the fertility is already declining after 30. And you will see there is a sharp decline beyond 35 and then more so after 40. And not only quantity, but the quality also starts declining when you age. And therefore, this whole Pandora of therapies and talk about how can we expand the reproductive window. And you can see that this is the spectrum of poor ovarian reserve women, wherein we are looking to increase the ovarian reserve by somehow putting stem cells or PRP or some other new experimental therapies are being tried so that we are able to give a family a child, a couple a child, in spite of that she has very poor ovarian reserve. You will, as per the Posidion classification of poor responders, you will see there are young women which have adequate ovarian reserve, but they don't respond. And the young women who do not have, the older women who do not have good ovarian reserve because of their age-related decline, they also need to have the children and the eggs. So nature has invented reproduction as a mechanism for life to move forwards, as a life force that passes right through us and makes us a link in the evolution of life. So we have to educate our women. So can we expand the reproductive potential by different therapies is the question which I am going to answer. By stem cell therapy, which Dr. Naina has elaborated upon how stem cell therapy, she is using it for the endometrial regeneration. So can we use it for regeneration of these dormant follicles which are sleeping in the ovaries, or by putting platelet-rich plasma, which in the morning we saw how beautifully demonstrated in the workshop, how can we prepare and inject, and through somehow in vitro activation and cell encapsulation. These are 4 therapies which are, sort of considered and it's still under experimental trials, that how can we expand the reproductive potential of a woman. So it is time to rejuvenate our ovaries, because our women are not ready to have the child when the ovaries are young and they can produce, give you healthy eggs, and then you want to expand the reproductive potential by rejuvenating the ovary. So what do you mean the words rejuvenate? Rejuvenate, the literal meaning is give new energy or vigor. So what is the ovarian rejuvenation? So it is defined as a procedure which is intended to reawake the egg maturation and the development within the ovary by activating the dormant follicles. As I had shown you that at 37 years, you have 27,000 follicles lying in the ovary, but they are most of them are in the dormant stage. So can we reawake those sleeping follicles to be coming into the FSH dependent cycle so that they can be recruited in the cycle and they can be used for producing the embryos? So stem cell therapy, Dr. Naina has already elaborated upon the different types of stem cell, that you have pluripotent embryonic stem cells, which can be produced through endoderm lining, the mesoderm lining, and the ectoderm lining. And you have multipotent stem cells, which have the affinity to differentiate into different cell lineages, whichever you want, the muscle fibers, the cardiac fibers, or the endometrial lining. They can be differentiated as per the design of the experiment. And the human stem cell, the applications we have listened to her about. It is not only in the field of reproduction, in different other lines also we are using human stem cells. So the stem cells have different immunomodulatory effect. They have anti-fibrotic effect, which is being used in the endometrial cell regeneration, and it produces different type of IGF, VEGF, HGF, and the angiogenin factors which regulate the angiogenesis and causes the increase in the blood supply, and it causes the folliculogenesis. So in endometrial regeneration, Dr. Naina has beautifully demonstrated through her 12 patients in which she has tried and shown very positive effects. I'm sure it is very motivating for all of us until we get a green signal, because by ICMR this therapy is still experimental and is still not given license to be used freely on the patients. The type of stem cell, we have just discussed that we have mesenchymal stem cell, extraembryonic stem cells, and there are pluripotent stem cells. So she was mentioning about that you can have amniotic stem cells, and you can have umbilical cord, bone, and adipose tissues. So they are multipotent stem cells. They are readily available, and they are poorly immunogenic because you can use allogenic source. You can take the bone marrow, aspirate the bone marrow from the sternum or the iliac crest, and then you can make them differentiated stem cell and inject the stem cells. So the source of stem cell, most of the studies has been bone marrow. Bone marrow serve as a source of germ cells. There are hematopoietic stem cells and the primordial germ cells, the origin being during the embryogenesis. The bone marrow contains mesenchymal stem cells and hematopoietic stem cells. These are either distinct cell lineages or the true progenitor cells or multipotent population left during the embryogenesis. And they can be used to regenerate or rejuvenate the ovary. So the available studies which have been done for ovarian rejuvenation have used the bone marrow derived stem cells. So they have two sources. They can take it from the peripheral blood after you give the GCSF treatment. When you give the granulocyte colony stimulating factor injections for 5 days, what happens? There is rapid proliferation of the stem cells, and in the peripheral blood, you get the stem cells in the blood. So after the GCSF treatment, you can have bone marrow derived stem cells isolated from the blood, and you can use the stem cells. And the second source, if you do it is a little invasive procedure, but more cost effective because the GCSF treatment is a little expensive. So you can do iliac crest aspiration, and then from there bone marrow is aspirated, and then from bone marrow you can prepare the bone marrow derived autologous stem cell. So the first study was published through the bone marrow derived transplantation of generating immature oocyte and rescues long-term fertility in a preclinical mouse model of chemotherapy-induced premature ovarian failure. So this study was published by the Japanese group in the Journal of Clinical Oncology. And after the study came the second study by Sonia Hurd's group, who has been the pioneer in bone marrow-derived stem cell application for the premature ovarian aging or for the rejuvenation of the ovary. So they have studied them successfully first in the animal model, and then came the human study by the same group, the Sonia et al. Group, in which they looked at evaluating the autologous stem cell ovarian transplant, the ASCOT trial on the ovarian reserve, and subsequently they did IVF outcome on which who were poor responders with very, very poor prognosis. And they concluded that the ASCOT optimized the mobilization and growth of existing follicles, possibly related to fibroblast growth factors and the thromboplastin 1 with epipheresis, and the ASCOT improved the follicle and the oocyte quality, enabling pregnancy to women who are poor responders previously with limited ovarian ovarian oocyte donation. So, and the third paper also came from the same group, Sonia et al. Group, and they published a beautiful review And in this review, they reviewed the techniques recently listed in both the animal and the human models to provide a stable state-of-art stem cell ovarian transplantation to achieve the ovarian rejuvenation in the patients with diminished ovarian reserve. And the summary of this beautiful review was that stem cell may be a relevant therapeutic alternative for ovarian regeneration and follicular development in the patients with impaired ovaries, such as poor ovarian responders or women diagnosed with primary or premature ovarian insufficiency. And then another review came that the stem cell therapies are attracting attention in the field of regenerative medicine, and it is advancing rapidly. Many recent studies have applied stem cell therapy to treat the reproductive system diseases. However, data are not yet available as to whether this therapy shows enhanced therapeutic effects. And this paper very critically analyzed the different published work and gave an opinion that we need more data before we can apply this to everyone. So the further study, which is very recent publication with Sonia Hurd's group again, and in which they were looking at the effect of bone marrow derived stem cells, and they concluded in their paper that the findings suggested that stem cell secreted factors present in both the granulocyte colony stimulating factor, mobilized and umbilical cord blood plasma could be an effective treatment for increasing the reproductive outcome in women with impaired ovarian function owing to several causes. So there are various successful animal model studies published in the literature using bone marrow derived stem cells. And in bone marrow derived stem cells, the estradiol level they used in the patients where estradiol level dropped and the FSH level raised 21 days after the mesenchymal stem cell therapy in damaged ovary after chemotherapy and regains functions after transplantation. And bone marrow derived mesenchymal stem cell transplantation produces healthier ovarian follicle and less apoptosis of ovarian cells. And the significant reduction of atretic follicle and the significant increase of antral follicle and the secondary follicles were observed. And the bone marrow derived mesenchymal stem cell treatment resulted in higher number of pre-ovulatory follicles, the metaphase 2 oocytes, embryos, and promoted the ovarian vascularization and reduced apoptosis. Now, this first human study, which is published by Sonia Hurd's et al., the ASCOT trial. So it was published first time in fertility sterility. This ASCOT trial was published in 2018. And this trial, they recruited 17 poor responder patients, and it was a prospective observational pilot study. And the intervention was similar to what Dr. Naina was describing. The intra-arterial bone marrow derived stem cells were delivered into the ovarian artery. And the serum AMH and FSH were measured every 2 days for 2 weeks, and then every week after 4 weeks, and then every month after 5 months. And the result of this study, they showed that there was increase in AFC, which was statistically significant on day 15 after the bone marrow derived stem cell injection, although both AFC and AMH increased during the first 4 weeks after the ASCOT therapy. And they concluded the ASCOT improved the follicle and oocyte quantity in poor responders mediated through bone marrow derived stem cells soluble factors such as fibroblast growth factor 2 and the thromboplastin 1. So there was a global conference on tissue engineering, regenerative and precision medicine, which was held in San Antonio in December 2016 to discuss different regenerative therapies available. And in this, the autologous stem cell transplantation in patients with idiopathic premature ovarian failure paper was published and studied by by Hala et al. From Egypt. And this paper said the aim was to investigate the role of transplantation of autologous bone marrow derived mesenchymal stem cells in premature ovarian failure. It was an open label single group safety and efficacy study. And the sample size was not small. You can see they studied it in 30 patients. And the method was same, like they gave the GCSF injection to get the stimulation, and they post iliac spine and bone marrow aspirate, and then they took the mesenchymal stem cells. And they showed that 86.7% showed fall in FSH level with the rise in E2 and AMH level at 4 weeks of injection, which lasted up to 48 weeks. And 60% showed ovulation. They had 1 spontaneous pregnancy and 3 underwent IVF. The outcome is not revealed in this paper. So the conclusion was that autologous bone marrow derived stem cells may improve the conditions in patients with premature ovarian failure. And this another paper, it's actually a case report which is published by one of our colleague only, Dr. Sunita Tendulwarkar. This case report was published in our own Journal of Human Reproductive Sciences in 2018. And in this case report, they showed that the 45-year-old perimenopausal female, in which they did a bone marrow aspiration, 120 ml bone marrow was aspirated using 13 gauge Jamshidi needle. I think 120 ml is quite a lot of volume actually to aspirate from the bone marrow, because when we did our study, I will share, we were not aspirating so much of bone marrow and will not get, it's a very painful procedure. 16 ml bone marrow derived stem cells separated using CEPEX. It's a fully automated closed capability system, some kind of a machine which separates the bone marrow and the bone marrow derived stem cells, and they injected through laparoscopy through the needles directly into the ovaries. And what they observed that after 8 weeks, the patient was ready to undergo controlled ovarian stimulation, and she produced 3 oocytes, and 1 grade A compacting embryo was frozen on day 3, and later a frozen embryo transfer resulted in a pregnancy and a live birth. And this is a tremendous piece of work that you can see in a 45-year-old perimenopausal female. You were able to give a baby of her own from her own oocyte. Isn't it exciting? And this was a really good piece of work. And there are some other studies also published similarly wherein they use bone marrow derived stem cells. In this study, there was a series of 33 patients with idiopathic POF or POI and low ovarian reserve. And in this, similarly, bone marrow derived mesenchymal stem cells were injected into the ovary through laparoscopy route. And the main finding in this study is still ongoing, so we don't know the result. Most of the studies I could see from the trial registry that these trials are registered and they're ongoing, and the results are not available. So on the pattern of SCOT1, the SCOT2 trial is still ongoing, and on the pattern of ASCOT, there's a ROSE trial, which is rejuvenation of premature ovarian failure with stem cell, ROSE1 and ROSE2. These 2 studies, they are ongoing. We are awaiting the results of these studies. They are still ongoing. So when such exciting piece of work being done by everyone, so we were also excited to do the similar kind of work which we did as a pilot project at AIMS. And it was very, very difficult to get approval to do the stem cell research, because we have a national stem cell ethics committee. You have to take first the institutional ethics committee will give the approval, then you have to go to the national stem cell ethics committee, wherein you have members from ICMR and from other research organization, and they will first, you have to present the data that whatever work has been done on animal models and the human models, because they do not consider this therapy still to be applied to all, and it is under experimental trial. And this study was done in 20 19, we got the approval and we started the trial of autologous bone marrow derived stem cell transplantation, and we called it on the basis of ASCOT, we said TAMSCOT trial in young women with diminished ovarian reserve for ovarian rejuvenation. And this work, we actually recruited, the sample size was small. Let me check that. We took the average age of the women in this was 29 to 34 years. And they were all young patients who were poor responders, or they were having poor reserve. And the poor reserve was defined as less than 5 AFC and AMH of less than 0.5. And the data from this trial, this was a prospective open label non-randomized controlled trial, and the trial registration number was this, and we had taken a proper approval, and the sample size was 22, and the diminished ovarian reserve, as I said, that the AFC was less than 5, but the AMH was less than, not 0.5, sorry, 1.2 nanogram per ml. And in this study, what we did not do GCSF mobilization. We took the help of a hematology colleague who aspirated 2 ml of bone marrow from the iliac crust. And then we sent it to the National Stem Cell Facility. And the National Stem Cell Facility, which is located, we are privileged to have that at AIIMS only, and they prepared the stem cells. And the average number of cells which we injected, the mean number of stem cells which we injected were about 77.7. And I think these were mostly CD33 cells. And what we observed, that in first follow-up after 1 month we did, and the second follow-up we could not do because in between there was a lockdown. 2020 came and we started our study in later part of 2019. And after March onward, there was a lockdown. So we could not call our patients for in-between follow-up. So after 6 months, when we reopened in the November time, when the corona was, the cases were less, then we called for the second follow-up. And what we found, that there was 68% improvement in AFC and AMH, and the effect persisted for 10 months follow-up. We were wanting to do the IVF in the same patients, but then by the time we observed these patients, the second wave of corona came, and we could not do the IVF in these patients. And till now, no patient has come to report a spontaneous pregnancy in our trial. And the conclusion of our study was that the bone marrow derived stem cell injection does improve the AMH and AFC in these patients, but we could not demonstrate that what was the endpoint, that whether we were able to give them babies or not. So I would not say that we were disappointed, because by the time the first wave came and then the second wave came, and after the second wave, when we called them, so most of the women did not persisted the effect which they had shown the initial improvement. The improvement did not lasted beyond 1 year. So we did not wanted to do the re-injection of stem cells, because by then we had started another trial of PRP, and we were getting very good results on PRP. So that trial is ongoing. We have already recruited 80 patients, and out of 80 patients, we've already done IVF in 15, and we have achieved 4 pregnancies out of 15 from PRP. And therefore, we did not consider injecting stem cells in these women, because this is more invasive, and making PRP, injecting PRP is less invasive, and therefore we did not call these patients again for therapy. So we all know that there is age-related decline in fertility, and the education, what is the need of the hour is education and enhanced awareness about the effect of age on fertility is essential in counseling our patients. Risk of pregnancy loss, women older than 35 years should receive an expedited evaluation and undergo treatment after 6 months of failed attempts to conceive or earlier if clinically indicated in women older than 40. So We have to tell our women, being a mother is not about what you gave up to have a child, but what you gained from having one. So education and enhanced awareness of effect of age on fertility is essential in counseling patients who desire pregnancy. Women older than 35 years should receive expedited evaluation and consider treatment. And then only probably what the graph I was showing you, the global fertility crash and India going below the global standards in terms of fertility and our population shrinking very rapidly can be restored back. And as a reproductive physician, reproductive medicine physician, all of us have a responsibility on this front, that none of the women should require this treatment beyond 35, 37. They should be able to complete their family before that. And women, those women who are young and have poor ovarian reserve in the ages, like sometimes you find a 28-year-old, 30-year-old, and for these therapies should be reserved for those women. And we should do a very good counseling to our patients attending in fertility clinic. And I bring greetings on behalf of my team from AIIMS. And once again, I thank from the core of my heart to everyone for this wonderful workshop and giving me the opportunity to present my work. Thank you very much for patient hearing.
Thank you, ma'am. That was truly a very wonderful, elaborate and comprehensive session. Just a few questions, ma'am.
Yes.
So, ma'am, when you said that you used the bone marrows and injected them into the ovary, how did you do that, ma'am? Was it through a laparoscopy or vaginally?
No, it was vaginally. I did not. I used the least invasive route. It was through the transvaginal, like how we do the egg collection. The same, the oocyte aspiration needle was used, and we injected the stem cells into the ovary through transvaginal.
And ma'am, when was that done? In a cycle before or a couple of cycles before, or
no, so we used to do these women who had the criteria, inclusion criteria fulfilled, and they wanted to undergo this experimental trial. After they had finished their menses, we would recruit them and then inject. And then the plan was that we will call them as according to the escort trial, that we call them after a month and then second month. And then if they have enough of AFC and AMH, we will be able to offer them IVF. But unfortunately, because of the corona pandemic, we could not take them for IVF. And after 1.5 years, the effect did not last. And then by then we started our PRP trial, which is giving us very good results. It is ongoing. And we will publish our results very soon, and we will share the results. And therefore, we did not thought that this is prudent, that this is more invasive therapy that you take bone marrow. Yeah, the making PRP is very easy, and it is giving us very good results. So we did not do a repeat stem cell injection in them.
Thank you, ma'am. Just taking this forward, you've used it in the endometrium as well.
Yes.
And how was that, ma'am, the mode of delivery for the endometrium?
Yes, so in endometrium, I published that paper, and we have done a 5-year follow-up study also after injection. So what in the endometrial regeneration, we did not do the spiral artery catheterization retrograde and then injecting into the arteries. Herein we went into the transmyometrial, into the myometrial endometrial interface. We were putting the stem cells there, and then we were giving high doses of estrogen. And what we found, Tanya, in that study, that the endometrium did regenerate in the patients where there was, some amount of endometrium was present. Meaning by that, those who were grade 5 Asherman, they did not respond. So for this therapy to work in endometrial regeneration, it is very, very necessary that they should have some amount of basal layer of endometrium available for regeneration. And we showed in that paper that we achieved 4 pregnancy out of 35 women. We had injected the bone marrow derived stem cells.
Thank you very much, ma'am. Truly enlightening. Thank you. Moving on now we have yet another excellent speaker and a very important topic. So very warm welcome, Madhuri ma'am.
Tanya, there are two questions in
Sure,
the
ma'am,
chat
please.
box. If you... I think one is, are you stimulating patients after how much gap of PRP? And the second one is, what range of AMH in your patients of ovarian
Madhu,
PRP?
I'm going to take this up in the panel because we are running a little late and Hemant is waiting. These all questions will be there in the panel.
Yeah, they've come in the chat box, so that's right.
Thank you, ma'am.
I can answer if you want.
No, they're in the chat box.
Okay.
They're not my questions. Anyway. They're from the chat box.
So Neeta ma'am, please hang on for a bit longer and be with us in the panel. I shall move on.
Sure.
And Madhuri ma'am needs no introduction. Ma'am is the director of Dr. Patil's Fertility and Endoscopy Center.
Tanya, they introduce me, so I'll go straight to my talk.
Okay. So extremely important. We've learned the nuances. Now we really need to know Indian national guidelines for stem cell research. What we need to know, and Madhuri ma'am is going to enlighten us on the fineries of this legality. Floor is yours, ma'am.
Thank you, Nalini and Fertivision, for inviting me here today. So after all the clinical talks, I'm going to talk something very theoretical, and I think it's going to be very boring because I also found it boring when I prepared my talk. So I'm going to talk to you all on the Indian national guidelines for the stem cell research and what we need to know. So we have already heard that we could have stem cells from the embryo, from the fetus, as well as from the adults. And basically, in the adults, what we use is the mesenchymal or the hemopoietic stem cells, as well as we also have the neural as well as intestinal. So if you look at the adult stem cells, basically they are pluripotent, multipotent, oligopotent, as well as unipotent, whereas embryonic are basically totipotent and pluripotent, and the fetal stem cells are pluripotent and multipotent. So today what we're going to look at is the regenerative. What we're talking about is the regenerative medicine, and we've already heard the different indications for using stem cells in infertility practice. So the national guidelines for stem cells was drafted under collaboration of ICMR and the Department of Biotechnology and was published in 2017. And these guidelines are a part of the continuous endeavor to tackle the scientific, technical, and perceived challenges in the field of stem cell research. And it also seeks to facilitate the safe, ethical, and regulated translational as well as clinical stem cell research by engaging all stakeholders proactively. They basically would prevent the premature commercialization of the unproven stem cell therapies, help generation of new knowledge based on the sound scientific rationale while addressing all the ethical concern. And it also clarifies the ambiguity over who has the legal jurisdiction over the uses of the stem cells. But we all spoke a lot about PRP and the bone marrow stem cells, but you can see that this has been excluded and was not under purview of these guidelines. They also excluded the research involving the non-human stem cell products and derivatives, and this guidelines again did not apply to the hemopoietic stem cell research, which was indicated or approved in the treatment of various hematological and immunological and metabolic disorders, where standard for medical care has already been established. Coming to the ethical and scientific considerations, we know that health and safety and right has to be preserved, and therefore it is mandatory to have a video consent. We need to screen them for all major transmittable diseases, all the viral diseases, and basically the intellectual property rights of the donated material, if we are using a donor for the stem cells, will not vest with the donor, but may be shared, and this has to be mentioned in the informed consent. And if commercialization brings any financial benefit, this has to be passed to the donor or to the community. So when we look at the ethics regulation from the MCI, it's important that the physician should neither exaggerate nor minimize the gravity of a patient's condition and will serve the best interest of the patient as well as the family and inform them about the correct prognosis. It is also important that at every consultation, the benefit to the patient is of foremost importance, and this needs to be informed. A physician should clearly display his fees and other charges on the board of his chamber and or hospital he is visiting. So it's very important that we need to inform them about the cost of treatment. Moreover, it's important that there should be no advertisements or publicity either done alone or in conjunction with others, which is of such a character so as to invite attention to him or his professional position, skill, qualifications, achievements, attainments, and specialities, appointments, as well as his association. And therefore, we know that this should not be done. Coming to the key elaboration on the manufacturing process, basically the cell processing and manufacturing stage is to be compliant with the requirements as per Schedule M of the Drug and Cosmetic Act to ensure the rigor of quality control and quality assurance for the product development. The stem cell products and derivatives can also be processed in a central drug standard control organization certified as good laboratory practice and good manufacturing process facility. The institutes or laboratories must also obtain the National Accreditation Board for the testing and calibration laboratories accreditation when processing the stem cell products as well as its derivatives for human use. When we look at the scientific consideration, it is mandatory that appropriate safety measures to mitigate the risk of acquired mutation in the pluripotent stem cells is taken. Short-term and long-term viability and potency testing of cryopreserved or stored products is important. The CDSCO certified GLP and GMP facility is required to process the stem cell products and its derivatives. For preclinical studies on animals, all laboratories must obtain good laboratory practice certification from the Department of Science and Technology. Institutional NABL accreditation is mandatory when processing stem cell products as well as its derivatives for human use. And when we have to start practicing the use of stem cells, it's important that we submit the clinical trial application for evaluating the safety and efficacy, and the requirement for permission for use of stem cells is taken, and the post-approval documentation of its use and results is mandatory. Then coming to the regulatory framework as per the national guidelines, and this basically is for the embryonic stem cells as well as the cord blood stem cells and the other stem cells which do not still have any evidence. So these 2017 guidelines reiterate that any stem cell use in patients other than that for hemopoietic stem cell reconstitution for approved indications is investigational at present. The clinical trials using stem cells should be a compliance with the Schedule Y of Drug and Cosmetic Act 1940, as well as the GCP guidelines of the CDSCO and the ICMR ethical guidelines. All international collaborations require approvals of the respective funding agencies, followed by approval from the Indian Health Ministry Screening Committee. In situations involving a conflict in the scientific and or ethical aspect between the collaborators, the existing Indian Guidelines Act and acts and regulations shall prevail for the work to be carried out in India. The stem cells and the derivatives fall under definition of drug as per the Drugs and Cosmetic Act and are categorized as investigational new drugs or investigational new entity when used for clinical application. The investigator should follow the clinical trial template for protocol as per given format and submit the application to the office of the CDSCO. All clinical trials using stem cells must be registered with the CTRI. The review, approval, and monitoring of the clinical studies involving stem cells will be done at two levels. One is at the by the National Apex Committee for Stem Cell Research, and the other is institutional by the Institutional Committee for Stem Cell Research. The clinical trials can be permitted only in institutions and hospitals having registration with the Institutional Committee for the Stem Cell Research and the Institutional Ethics Committee. For multicentric trials, all participating sites should obtain approval from their own ICSR and IECs. The Institutional Committee for Stem Cell Research shall not act as an Institutional Ethics Committee. Separate approvals must be obtained from both the committees for any human stem cell related projects. And the quorum of any institutional stem cell research committee includes a member of 8 people, which includes a chairperson and a vice chairperson, along with the secretaries. And basically, the work is carried out by the chairperson. The member of the quorum, except the member secretary, should never have been affiliated to the institution where the research is going to be carried out. The subject expert with no conflict of interest should be appointed, and he should not be affiliated to the same institute, and he may then be invited for specific projects. The invitee will not have any voting rights. The National Apex Committee for the Stem Cell Research may nominate an observer on the ICSCR to educate and create awareness regarding the existing guidelines as well as regulations. Ex-employees of the institute can become a member only after 2 years of leaving the institute. All clinical trials must have a medical specialist registered with the MCI and holding a MCI approved postgraduate qualification in the subject domain of the trial. All medical professionals involved in the clinical trial should have a valid good clinical practice certification. Human participants enrolled for the clinical trial are not liable to pay any charges towards the procedure, investigations, or hospitalization related to the trial. A video consent shall be recorded as per the CDSCO guidelines for audiovisual recording. Identity of the donor, if a donor is used, shall be kept confidential at all times. And as I already said, advertising and publicity to any mode by the clinician is not permitted and can be prosecutable. Coming to the different levels of manipulation involving the stem cell research, it has been seen that before any clinical application, transplantation, or translational research, the stem cell products and derivatives may undergo a variable degree of in vitro or ex vivo processing that carries the risk of contamination and may also lead to alteration in their properties, which may vary according to the degree and the type of manipulation. And therefore, we have 3 levels of manipulation. One is minimal, wherein the processing period must be within 72 hours. The second is substantial, wherein you require a CDSCO approval along with the ICSCR and IEC clearance, and major, where you have the CDSCO approval after clearance from the National Apex Committee for the Stem Cell Research through the Institutional Committee and the Institutional Ethics Committee. So when we talk about the 3 different levels, the minimal basically is processing, where the processing neither alters the number nor the biological characteristics and functions of the cell, and it is basically utilized for reconstruction, repair, or replacement. For example, using a bone marrow, peripheral blood, umbilical cord blood derived mononuclear cells, or bone marrow concentrate given only by the intravenous route. When we talk about substantial, basically, it is ex vivo alteration in the cell population, which in the form of expansion, cryopreservation of cytokine-based activation without alteration of the cell characteristic as well as function, and its utilities for reconstruction, repair, or replacement. Whereas major, they basically involve the genetic and epigenetic modification of the stem cells, transient or permanent, or of cells propagated in culture, leading to alteration not only in their numbers, but also in the biological characteristics as well as functions. Again, there are 3 categories for research involving stem cells. One is permissible, wherein research involves establishment of new embryonic stem cells or induced pluripotent stem cell lines. Restrictive is where the research involves human pre-implantation embryos processed by IVF, ICSI, or somatic cell nuclear transfer to derive the embryonic stem cell lines. And the third is prohibited, wherein research involves human germline gene therapy as well as reproductive cloning. In vitro studies require prior approval of the IEC as well as the ICSCR, except studies involving established human cell lines registered with the ICSCR. In vitro studies on pre-implantation human embryos must be carried out within 14 days of fertilization or formation of the primitive streak, whichever is earlier. Derivation of new embryonic stem cells or iPSC lines from human embryonic or somatic cells respectively must have prior approval of the ICSCR and the IEC. Uterine implantation, either human or animal, of manipulated cells with the intent of developing a whole organism is totally prohibited. Then coming to the translational research, which includes clinical trials involving stem cells, the preclinical studies and the clinical trials using stem cell products and derivatives for repair or regeneration of the damaged tissue and organs, as well as other clinical applications in conditions where use of stem cells has not yet reached the standard of medical care, must abide by the following norms. So for the preclinical testing, it requires prior approval from the IEC in humans, as well as it also requires from the institutional animal ethics committee when used in animals, smaller animals, and committee for the purpose of control and supervision for experiments in larger animals. The product testing must include safety as well as biodistribution and the immune rejection studies. Single and repeated dose toxicity studies also should be performed in relevant animal models. The risk of tumorigenicity, genotoxicity, and developmental toxicity must be assessed on the intended clinical use. Whereas clinical testing requires prior clearance from the ICSCR, IEC, as well as the CDSCO, and must be registered with the CTRI. Any protocol amendments and deviations must have clearance from the ICSCR, IEC, as well as the SCO. Follow-up period of minimum of 2 years is mandatory whenever a clinical testing is done, and establishing data safety monitoring board is mandatory. All adverse events occurring during the clinical trials must be reported to the IEC, CDSCO, as well as NAC, SCRT, and through the institutional committee of the stem cell research. Trial records is to be maintained for minimum of 15 years, and that is very important. Coming to the banking of stem cell products and its derivatives, as of now, there is no scientific basis for the preservation of cord blood for future self-use, and this practice therefore raises a lot of ethical and social concerns. And we know that we have several stem cell cord blood banks which promote or advertise stem cell cord blood banking. And it has been said that the banking of umbilical cord blood or human embryonic stem cells and induced pluripotent stem cell lines is only permitted in institutions currently licensed by the CDSCO. Commercial banking of all other biological material is not permitted until further notification. Such institutions, if involved in the stem cell research, must constitute the Institutional Committee for Stem Cell Research, which is registered with the National Apex Committee for Stem Cell Research, and also should have a standard operating procedures for all banking and release of the material. The biological material can only be released to institutes who have registered into Institutional Committee for Stem Cell Research and also have the Ethics Committee. Coming to the procurement of stem cells, the IEC and the ICSCR shall review and approve processes for procurement, and if cells and tissues have been developed utilizing IVF, clearance from the NAC-SCR is mandatory. Archival period of stem cell lines and related information has to be maintained for 10 years. For procurement of fetal or placental tissue, processes must comply with all obligations under the MTP Act. Medical person responsible for patient care and the investigator using the fetal material shall not be the same. Consent for fetal tissue donation should be obtained in advance and not just before or at the time of the procedure. If there is disagreement between parents, the mother's wish shall always prevail. Consent for donation of blastocysts for establishment of human embryonic stem cell lines should be obtained from the donor at least 24 hours in advance. Donors retain the right to withdraw consent until the blastocysts are actually used in cell line derivation. Coming to the exchange, we know that import of stem cell lines for basic research will not require no objection certificate, but those for clinical trials and originating overseas require import clearance from the Central Drug Standard Control Organization. For export of indigenously developed cell lines, IEC and ICSCR clearances must be obtained and submitted along with the material transfer agreement during the review of such research proposals. We also need to have legal provisions because stem cells and cell-based products are regulated as drugs. Only stem cell transplantation in certain blood disorders do not require prior approval. Conduct rules under the MCI for doctor governs the treatment using stem cells also. So I would like to end by the following take-home messages: that the process of reviewing and monitoring the stem cell research will now be administered separately at the institutional as well as at the national levels. NAC SCRT is to monitor research activities at the national levels, whereas ICSCR shall approve and monitor the stem cell research at the institutional level. It is mandatory for all the institutes and entities engaged in stem cell research to establish an institutional committee for stem cell research and register the same with the National Apex Committee for Stem Cell Research and Treatment. ICSCR will provide periodic reports regarding the status of the stem cell research to the National Apex Committee. Consent protocols prepared by the National Bioethics Committee for tissue collection for human stem cell research should be followed. Vacuum of governance or bioethical behavior around stem cell activity in India has always been more problematic than a simple failure to adequately enforce the guidelines through statutory or the non-statutory means. Thus, there is a requirement of more clarity about the implications of the new rule to be sought from the regulatory authorities. Guidelines concerning the stem cell research are even evolving, and better provisions will always be required as per changing international standards and the current guidelines, which is a significant step in this regard. Current guidelines has tried to encompass the major government regulations, institutional oversight, and communications, enclosing basic and translational stem cell research, largely catering to the regulatory ambiguity. And I thank you all for a patient hearing.
Wonderful. And this is something we all needed a lot of clarity upon. I think in our minds, we all are clear that there is a discrepancy between stem cells and PRP and how we should manage both separately, with a lot of legal aspects with the stem cells, and hopefully more will come up with the PRP, including separately for the endometrium and for the ovary. If there are no more questions, we shall move on to the next session. Thank you all. Thank you, Naina ma'am, Neeta ma'am, and Madhuri ma'am for a truly incredible session. And please join us for a very nice talk followed by a really exciting panel. Thank you.
Moving on to the next session, I'd like to invite Dr. Heman Gupta. He is MBBS, MD, and PhD, founder of Genesis Therapeutics in Gurgaon. He'll be speaking on technical aspects of bone marrow-derived stem cell preparation in reproductive medicine. Over to you, sir.
Hi, hi everybody. I think all the eminent panel here available today has pretty much got everything covered. I think there's very less that I have to add, but I'll give you a little introduction about our company and what we're doing. Let me just share the screen. Are you able to see my screen, please? Okay, so as a company, we've been pretty much operating on a stealth mode. We were early based out of California, and now Very recently, we started in India. The core fundamental science that we're dealing with is stem cell science only, and we've been working on setting up different kind of clinical trials for companies that are based out of in US, requiring a majority of the work to be done with stem cells. We understand the legal process back in the US. In India, we're trying to understand, and very recently we started here. The topic that's been given to me is to cover about how to prepare bone marrow stem cells. I'll go through that in a bit, but just to give you a little idea, as has been already covered by the panel before, we've got four kinds of stem cells here. Largely, we are talking about mesenchymal stem cells that can be derived out of bone marrow, fat, endometrium, and wharton jelly. So these are four kind of stem cells, and what we are anticipating is, because of the biological property that they possess, they also have, they've been very successful in showing potential mechanisms through the paracrine effect, which involves differentiation into a variety of cells, and that further propagate or supposedly will propagate the betterment of the conditions locally that we're trying to stimulate. Because we've already covered a lot of it, I'm not going to go deep into it. But what we've seen is from various kind of trials that have gone through in a variety of and have been reported in a variety of journals. These four different kind of stem cells have tendency to address a certain kind of conditions, and then they tend to derive certain functions that can be recorded. A disease that the bone marrow stromal cells have been used in ovarian dysfunction and endometrial disorders. The diseases have been CTX-induced ovarian failure, CTX-induced ovarian 24-gauge needle-induced AS, and refractory AS. The treatments were given through intravenous injections, local injections, tailwind injections, and uterine artery injections. Main results that we recorded were ovarian functions went up, restoration of ovarian hormone production went up, endometrial proliferation went up, and the reconstruction of endometrium was seen. The adipose-derived stem cells, we haven't covered in this, but yeah, they also tend to offer a considerable amount of help. They also tend to improve ovarian function, fertility, fibrosis goes down, and endometrial proliferation goes up. Then we have menstrual blood derived MSCs. They also help in overall ovarian weight gain, hormonal secretion goes down, ovarian function goes up, fibroblast growth factor 2 goes up, endometrial thickness goes up, pregnancy rate goes up. The umbilical cord mesenchymal stem cells also tend to possess a lot of promise. They tend to show the weight of the ovaries going up, estradiol goes up, follicle stimulating hormone goes down, estradiol goes up, ovarian function goes up, and variety of other things like the fertility of ovarian functions going up, and angiogenesis goes up, endometrial fibrosis goes down. This is the procedure we tend to follow. It's a pretty simple procedure. We use an adaptive method of isolated lower density mononuclear cells using centrifugation techniques, in which defibrinated blood is layered on a solution of sodium diatrazole and polysucrose and centrifuged at low speeds for 30 minutes. You tend to form different layers of which the mononuclear cells are isolated. We use the centrifugation gives us a layer of mononuclear cells or mesenchymal stromal cells that are contained in the branded plasma LF interfaces due to the density, and the palette is formed containing mostly high density lymphocytes, erythrocytes, and granulocytes, which have been migrated to the gradient to the bottom of the tube. We don't take that. We separate them. We take the mononuclear cells, and then they are incubated at 37 degrees, 5% carbon dioxide incubator. There's at this point in time, we separate these derived bone marrow stromal cells into three different lot sizes, of which one actually goes into the injection straight away, goes to the doctors, and then they administer it. The rest of the cells are actually incubated. what we've tend to seen is that the immediately isolated cells, they tend to show certain kind of properties, and because of the the extreme stressful environment that they have in different places and where the administration needs to happen, they may or may not be able to survive. So we want to actually also culture uh, uh, for 7 days. On day one, we see that cells are still mononuclear cells. On day two, we see some spindle-shaped, arrow-shaped cells are formed among the mononuclear cells. On day three, we see the spindle-shaped cells continue increasing. On day four, the spindle-shaped cells reach about 60 to 80% of the confluence. And then on day five, the spindle-shaped cells already form layers, forming the new using the new protocol. But this protocol continues further, and the fibroblast based cells grow out into a dense cell nodule. And on day seven, we see the cells reach 100% confluence, so no passage is required. On day four, we actually do the passage so that any of the unwanted cells are removed. So this is the protocol that we follow. These cells that are cultured then also given for further injections to the investigators to continue their line of protocol. What we've seen is that you sometimes are requiring more frequent injections than normal ones because of the environment that is continuously changing. And not just one single injection is good enough. So that's why we follow this kind of protocol. I'm really short of time. I think a lot of time got taken up. That's pretty much what I wanted to present as of now. And thank you so much to the panel.
Yes, thank you, sir. Thank you, sir. Is sir available? Sir, can you hear us? Sir, please switch on your screen. Hello, Dr. Hemant. Sir, can you hear us? I think he's muted.
I think maybe he's.
Hello, sir. Can you hear us?
No, he's not there. Yeah, I think.
Okay.
He's.
No, he is there. He's there.
I think he got connected now.
Thank you, sir, for this, for showing us how you prepare BMCs. So we'd like to just ask that some people, they just take out the BMCs, bone marrow stem cells, and they prepare and freshly they transfer. It's a little different from the protocol that you have shown us. So can you just elaborate what is the difference between the two and how the results in terms of efficacy and the results?
Yeah, so what we've seen is that the freshly prepared cells, they do take a lot of time to kind of incubate, and you may or may not see results that you expect over a period of time. But when you have already differentiated cells, which are moving from the mononuclear to mesenchymal, they do tend to possess better results that we are expecting. The results tend to come a little bit more faster than what you expect, and also this protocol allows you to supply more cells without having to aspirate the samples again and again. So while you have the opportunity of aspirating, you also have the opportunity of actually preparing the cells that maybe require in a bit more steady pace than what you typically don't do. So instead of doing it again and again, it's just a better protocol.
Is there any cell degeneration that occurs over time, like when we are waiting for so many days? Like
no, not really, because once you would have cultured it, and at the time when you're preparing the sample to be given for second or third injection, the samples don't really degenerate a lot. You're picking up the healthy cells and after passage, and then so only the good quality cells are being given. So, and also they're being checked for mortality. What percentage of it's there, is there any infection that's there or not, and it's thoroughly checked. and all of that gets thoroughly vetted, and you typically have a cell viability of more than 99%.
So what is the usual quantity of bone marrow aspirate that you would like?
Yeah,
Sufficient
I think 30 ml is more than enough. We do not tend to go more than 30 ml. And because we're culturing it, we also know that, you know, it's not about quantity, but it's about consistency and delivering it over a period of time that actually drives results. So volume wise, I mean, 30 ml is more than enough that we ask for it.
Okay, so because we're culturing it for so many days, so what is the cost that we would be expecting? Like,
yeah, so cost does go up a little bit, but it's, I mean, what's the cost? Let's look at that. You know, you're supplying nutrition, which today is not very expensive. There is a CO2 incubator. There's you know, you have to maintain a certain temperature. Today, I think the cost is not that high for these kind of things. So it does add to a cost a little bit, but yeah, that's not a lot of cost.
And Dr. Hemant, thank you first of all so much for you know, accepting the invitation, because this is a new field and we really want to know from experts exactly how to go about it. So one of the things which sort of came to my mind is when you are doing these passages and thereafter, how do you keep these or how do you transport these these cells to the endpoint as the clinician for whatever their uses?
Yeah.
What temperature are they kept? How would they be transported?
So we keep them at a room temperature. We do tend to maintain the temperature around 25 degrees. It can go up to 30 degrees, but if it's taken out and you know, properly bottled and the temperatures are maintained around 24 to 30, and you doing the delivery within 6 to 8 hours, there's no problem.
For you know, giving this. I think next time, since you're not going to be available for the panel, we'll call you again to understand a little more you know, in detail about how would we associate and how could we, you know, take in our patients and, you know, do a procedure and go forward with that. Thank you so much, Dr. Hemant. Anybody else wants to ask a question? Thank you, Dr. Hemant. Thank you so much.
Thank you so much. Thank you.
One
Everybody.
question: why don't you prefer the automated system which are closed, the SAPEX or the Angel or anything?
Yeah.
We also prefer manual. That's why I'm asking.
Yeah, I think they're good. I think they're good. Just because they're automated doesn't mean that they're actually going to get the quality and the consistency. It's very good if you take the sample and you check it and it's better through a process. Companies are always trying to automate it because they have to sell their product to somebody. I think the thorough process, taking it step by step, really works. It really is more. I mean, you would want to be doubly sure of what you're delivering, and I think that's what you're also doing, doctor. So the process is good, and there are machines that are trying to automate everything, but I've seen that their consistency varies quite dramatically, and most of the time when the consistency gets affected, you would actually not know. You would not even know that, you know, the consistencies got impacted, and then you're now dealing with a sample that's not even you have no idea what's in there. Many times we've seen that the machines, when there is some sort of a, you know, they're still mechanical equipments. I mean, they're still mechanical.
Yeah.
So you know, you have to really know if the machine is tuned and every time is tuned. It also saves a lot of time when you have a staff that actually prepares the samples and it's vetted through a process that gives you a sense of belief that yes, the process is thoroughly vetted and it's, you know, it's to the right quality. I'm not against the machines. I've just seen that out of our experience, if we do it, there's a difference. There's a difference between the automated process and doing it, you know, manually, you know, through the process, through the protocol.
What is the target of the harvest? How many million mesenchymal cells you would want?
Yeah. So see, there are different protocols, and I can go through it and then in much detail. I think this would not address the paucity of the positive time wouldn't address this whole, because there's a lot more behind behind the cell volume, we do tend to look at a volume which is reasonable enough depending upon the garden of conditions that you're dealing with. And sometimes, like I saw fantastic work that you've done, doing those arterial injections. I think because the endometriosis is a bouquet of problems, not just one injection helps, but multiple injections at different locations, and their and their repetitiveness would really help a lot. So while this could be a cure, this could be a very promising frontier, but I think what we lack is how much do we need? How often do we need? Are they really doing the job in that small amount of time that we want it to be, or do we need to wait a little bit more? So our organization is trying to build that data and trying to build that infrastructure around that controlled experiment that you would want to have, so that we could do it in a much controlled environment and then test it and build that data that currently is really lacking. Even with the 12 people trial that you did, I think if we were involved earlier back then, we would have built at least a quantum, at least 500 times more data that you would have now. So that's I think could be addressed in a more organized manner. I think there's a lot more involvement required, and the norms need to be relaxed a little bit, because there's a lot of work going on in stem cell science. There's absolutely plethora of work going on. It's just that when we come to kind of reporting it, the norms a bit just too much. So we kind of need to ease that out a little bit also. But I'm saying that we need to maintain the clinical cleanliness and the effective efficacy or the ethical conduct. But we also need to understand that we need to probably do a little bit more interventional procedures that would generate more data. So yeah.
Thank you, Dr. Hemant. Now we move on to the panel discussion. For panel discussion will be moderated by respected Dr. Nalini Kaur Mahajan ma'am. She is the Director of Mother and Child Hospital, Delhi, and President of Asian Society for Fertility Preservation. Now I'll invite the panelists. I invite Dr. Chitra Nayak. Ma'am, she is the Senior Consultant Reproductive Medicine, Cloud9 Hospital, Bangalore. We also have Dr. Tanya Bakshi. She is the Principal Consultant, IVF and Reproductive Medicine, Max Super Specialty Hospitals, Delhi. Dr. Padmaja Naidu, she is the Director of Naidu Fertility Center, Mumbai. Joining us online will be Dr. Firuza Parekh, ma'am.
No, if you come in, you'll come in front of
Dr. Firoza, ma'am. She is the Director, Fertility Jaslok International Fertility Center, and she is also the Editor-in-Chief for Fertility and Sterility Indian section. Dr. Nana Patel, ma'am, will also be joining us. Dr. Madhuri Patel, ma'am, and Dr. Neeta Singh. They'll all be joining. Over to you, ma'am.
Thank you, Simran. Can I just have the videos playing? So I'm going to, can you just play the video here, Simran? So I'm just going to change this panel around a little bit because of all these technical glitches that are happening. We can't get the presentation and the panelists at the same time. So I will play the video of the intravariant PRP. I'll play a couple of videos showing one in, where the visualization is better and the smaller ovaries where it is so difficult. And then we'll just move on to the discussion. It's not coming on the screen there. So these are so many problems till they get it sorted out. Maybe I can ask Neeta the question that people have been waiting to ask is how long after you put the PRP or the stem cells do you actually start the stimulation? नहीं तो मैं ये वो लोग क्वेश्चन नहीं सुन रहे मेरा देखिए डॉक्टर नीता है So Neeta, if you're hearing me, can you answer that question? Acha, acha. Naina, I think maybe I can start with you. Aage? Dr. Neeta, kya aa gaya video aaya ya? This is such a ridiculous thing. Naina, in the meanwhile, till they get the video, can you tell me how, how much time do you wait? Oh, there it is. Okay, so you can see the needle going into the ovarian tissue. And you inject a little bit, then this is a cyst aspiration needle, or you can use the pickup needle, but we find this easier because you can just inject, you don't have any attachments so far as aspiration and all is concerned, which we don't need in any case. So you can see the needle being pulled out and then taken into another portion of the ovary. And again, we are injecting something. And what we do to take care of the dead space actually is after we've instilled this, we take a little bit of plasma and then push it through so that whatever is in the leftover in the needle will also go through. And then we, take out the needle and then we move on to the next ovary, and you can see a similar thing here. So can you move on to the next? And you can see, how you just sort of do multiple places because the tissue is so little. And that is one of my major concerns is that, when people say put in 4 ml, put in 5 ml, put in this many ml, where is that fluid going? As one report very candidly accepted that much of what we put in actually goes out of the ovary. And that is, I think there was one paper who was very candid about it, and they admitted that not all of what we put in really stays within the ovary, and a lot of it actually comes out from the ovary. And what they felt was, and the explanation was that even whatever is there in the pelvis, maybe that helps, So now if you can, now in this particular one, we've taken the very, very small ovaries where you can hardly see, you can't even define what is the ovary. And, you had to look at where is the vessel and then make sure that you were going into the ovary and not really going anywhere else. And the ideal thing really is if there is a follicle or two, which you can see. In some ovaries, actually, you can see nothing. It feels very, very difficult. And I think what we did subsequently in those patients is actually gave them a little ovulation induction, identified the ovary by that follicle, and then went on to instill the intravariant PRP. Now you can see this is such a small ovary. A lot of what we are putting in, I think, is coming out. So some part, of course, must be absorbed in the ovarian tissue, but a lot of it is coming out. And you can see we are going through the cervix because, the ovary was stuck behind the uterus. And so a small ovary stuck behind the uterus, again, the accessibility, visualization is extremely difficult. So this is just to basically show this so that then we can move on with our discussion. I just want to play my presentation. Just wanted to share something with the presentation. So I just wanted to share our experience with this and just talk about a little about a couple of patients. So these are about, I think, 19 odd patients which we have done so far. Many of the results are still pending, but the maximum effect we saw was in these two patients where the AMH jumped up and the antral follicle counts really went up tremendously in both these patients. For this, the second patient, we are still stimulating her, and I'll just show you her pictures later. But for this one, she had had 3 previous IVF failures in this unit itself, not with me, but within Ferticity. And we had not got more than 2 or 3 or 1
one oocyte in one, 2 in the other, 3 in the other, but it never went beyond that. And then this one, you can see we had 10 oocytes after PRP, and we have 9 M2s, and now we have blasts frozen for her. And unfortunately, she also has a very thin endometrium, and we are working on that before we do the transfer. Now, these two patients, this patient particularly, you can see we didn't have much change in terms of antral follicle counts. The AMH looked as if it was up. The antral follicle counts really didn't go up that much. And even in terms of oocyte recoveries or M2s, they were more or less the same. I wouldn't say a huge difference, but she was again a patient of RIF with at least 5 IVF failures previously, and 5 meaning that she had 3 frozen transfers, 2 fresh transfers, which were negative. And with this, after the PRP, we had a positive result on her. Now, this patient here, again, she was a poor ovarian response. Not that her, we had enough, though the AFCs, looked like 2 and 2, and we got a little more 5 and 7 after PRP. In her first cycle, we had to cancel. She formed only 2 follicles, and we just converted it into an IUI cycle. But subsequent, after putting the PRP, we managed to get 9 oocytes, and she finally had a blast transfer, and she, she's currently an ongoing pregnancy, almost, I think, at about 6 months or so. And this patient, who's 40 years old, had a low count, very low AFC 2 and 2, with an endometriotic cyst, a terrible looking pelvis. We didn't see much improvement in terms of AMH, but she subsequently did form, 3 good, she had 3 good M2s, she formed 3 embryos, and she turned out to, she was very lucky. We have a positive result on her. So, what happens is when you have this kind of a positive result, you get very encouraged and you want to start, doing a lot more. But you look at this patient whom we had, oops, I'm sorry. Now, this patient had a very low count of AFC 0 and 1, and her AMH was 0.17. Now, after the PRP, and we did 2 for her, she did go on to increase AMH. But unfortunately, what happened, she took so long for stimulation, and I'll show you the pictures in a bit, that she finally discontinued her cycle. And in this particular patient, even though she was very young, she was 36 years old. There's another patient. I'm sorry, I can't get the cursor around here. Yeah, 36 years old patient. Here we thought that we will really get a good response in her, though her ovaries were small, AMH was low, but even, though we did a stimulation, but before PRP and after PRP, we could not recover any oocytes. So there is a lot more to be understood really before we sort of take this procedure on as something which we should offer to all the patients. But unless we offer to some patients and look at and see what are the results and what we should do, we really won't know how to go forward on it. So this is just to show you that patient with the pre-PRP of 1 AFC, post-PRP, you can see 1 follicle here, 2 follicles here growing after stimulation, but the stimulation took so long. Perhaps what I feel here is maybe if we had waited another month before stimulating her, we would have had more antral follicles which were, which had FSH sensitivity, and maybe we would have been able to stimulate faster, but that's the learning curve. And this was the other patient who I told you had a fantastic response. You can see from, she had 3 antral follicles in the previous, in the right ovary and 1 in the left. And now you can see post PRP, you're seeing 8 follicles here and 3 on the other side. And this of course is during her stimulation that, we've just started the stimulation, and you can see this beautiful picture, and I thought it was worth sharing with you. So having said that, then I think, can you get the panelists? So the first question that I would ask Neeta, Firoza, I want everybody's opinion on it, is when you have these small fibrotic ovaries, where do you think this 2 to 4 ml of PRP goes? Because I'm certain it doesn't go into the ovary. There isn't enough tissue there to hold that 2 to 4 ml. So what is your experience and would you like to share that? Firoza, can I start with you?
Yeah. Hi, Nalini. First of all, thank you very much for extending this invitation to me, and I thank the Fertivision team. Nalini, you're absolutely right. We carry out intraovarian PRP installation only on minimally stimulated ovaries. And for all our patients, and I will show you in some of my slides later on, why we do it on stimulated ovaries. It can be just clomiphene or letrose or clomiphene with minimal gonadotropins. That gives you a very good cavity or a very good space in which to deposit the PRP. Actually, we cannot deposit even in stimulated ovaries more than 2 ml per ovary. So 4 ml is the upper limit in our experience.
Naina?
First of all, I would like to thank you, Dr. Nalini. And now I will say that we as a rule do it 2 ml. It's never 4 ml. Very rarely when the volume is good and the AFC is low, we would go for 4 ml. But otherwise it is as a protocol 1 to 2 ml in each of the ovaries. When we see streak ovaries, the stimulated one is a good idea, but we would wait till mid-cycle so that one follicle can develop and the ovary can little bit expand. Then we aspirate it and we inject it. And very small ovaries, we prefer definitely laparoscopically rather than ultrasound guided, because in the laparoscope, you can literally hold it. And with the same egg retrieval needle, we go there. And whenever we inject in a small ovary or in a big, after injecting 0.4 or 0.3 cc, we wait for 30 seconds so that it can be absorbed before we again start injecting. So the ml is 2 ml, but at every 0.3, we wait for about 20 to 30 seconds and then we start injecting. So it's a very slow injecting procedure. That is what I think it can be helping.
Nita?
Yeah, I think what Dr. Naina said exactly. We also stick to 2 ml, ma'am. We haven't tried ever 4 ml. And in streak ovaries, what she said that in 2 patients, we did laparoscopically, but our experience was in very, very shrunken ovaries. We were not able to get good results even after the PRP injections. So our cutoff is that we do not take patients where FSH is more than 25 and where we are not able to see any antral follicle count. And what point you were trying to make that if the ovaries are small and FSH is still like within 20 and you're able to see some antral follicle 2, maybe 2 or 1, then we give definitely some stimulation and then put in PRP maybe on day 6 or day 7.
Dr. Chetty, can I ask you if you have a comment and if you would like to add anything here?
No, ma'am. We are bound by our ethics committee, so we don't do this intra-ovarian regenerative. However, we do PRP in endometrium. Just wanted to ask the panelists whether any particular day of the cycle they prefer, or if it is stimulated, or how do they go about doing it? Suppose a patient comes to them on day 2.
See, I think what Cheta, you missed them saying is that it is not during the stimulation cycle that it is done, but the ovaries are stimulated a little bit so that you can define that this is the ovary, this is the follicle. That,
yes.
So as soon as you start, it could be day 7, day 8, day 9, as soon as you see, because it is, yes, then because it's clearer to define the ovary. That is the important thing. And I think we already discussed on the laparoscopic route and when it should be done. And the day of stimulations has been discussed. So how to monitor the response? Dr. Firoza, can I ask you, how do you monitor the response? You put it in this cycle. Would you start, you would do the ovarian markers in the next cycle, then subsequently when would you do that?
Yeah. So Nalini, this is the whole crux of using the intraovarian PRP. We do a slightly different procedure. What we do, and if you look at Goujon's chart where he looks at the oogenesis, the entire cycle takes 85 to 90 days, which I'll show you later on in my slide. So what we do 3 cycles of intraovarian PRP. Each cycle is stimulated. And we simulate the whole cycle in a way that we even go about till egg retrieval. So that the first cycle of intraovarian PRP is a baseline cycle. That will tell us what is the AFC, what is the AMH, how many follicles were retrieved, how many eggs were retrieved, how many were mature, what was the quality, did they reach the blastocyst stage? And then we do the second cycle and the third cycle, because the third cycle is our defining cycle. We don't do the embryo transfer till we have obtained enough eggs and enough embryos to then continue doing the frozen embryo transfer. So there is a very interesting paper by Mello where they have used the same kind of a situation where they do 3 cycles and then finally do the definitive treatment. If you do that, you will see that the installation of the PRP is easier. You have a full idea of the AFC, AMH, maturity of the eggs, and that gives you more scientific data to help convince patients or guide them through the procedure.
Firoza, if I'm not wrong, in Mello's paper, he puts intraovarian PRP twice, but he doesn't put intraovarian PRP in the cycle in which he is stimulating for retrieval. So if I'm not wrong, correct me if I'm wrong, but what I understood from you is you're putting it in the cycle in which you're actually retrieving the oocytes as well. You're stimulating, putting it. So within that cycle, of course, it cannot make much of a difference, except if you think it makes a difference on the quality of the oocyte, and that to happen within a short frame of 72 or 3 to 4 days would be a question mark. So what would you think to that?
No, it doesn't. What we do is we do not transfer the embryos in the first cycle or the second cycle or even the third cycle, because as I explained you, the oogenesis wheel, if you see, it takes 85 to 90 days for oocyte maturity. So you cannot expect the PRP and the growth factors which are going to activate these dominant follicles to start acting right away. So that is the whole idea. We don't do it for 90 days. And
so then what is the idea of doing it in that cycle at all? Why not just do the pickup after 3 months rather than, do a pickup, put in the PRP, do a pickup, put in the PRP? Are you just pooling and just putting it alongside with actually looking at the third cycle?
What we do, the reason of doing it is we don't want to waste any oocytes. If we get oocytes in the first cycle, and that becomes your baseline, it becomes your baseline for comparing with the remaining cycles. And I'll show you some data which tells us how this has helped us when we are pooling the eggs and we get better quality blastocysts in the third cycle as compared to the first cycle. And we have a comparative group. We have done it with women who did not use the PRP, and we have good pregnancy rates in those who have used the PRP. So that becomes one kind of a parameter with which to compare where the PRP actually helps.
Neeta, can I request you to give your comments on this protocol? What do you feel about it, and do you think it really...
So, ma'am, what we do not do in the cycle. We do not, do the IVF cycle or do egg collection in the cycle when we are injecting the PRPs. Our protocol is that we call the patient after at least a minimum of 40 days. And then we looked at post-menstrual, of course, on day 2, and we compare the AMH, we measure the AMH levels and AFC. And if we see significant improvement, most of the time we see more than double. And if we see significant improvement, we recruit that patient then and there in the IVF cycle. And if we do not find significant improvement, then we wait a month again and call her after 3rd month. And by the end of 3rd month, we find that most of the patients have got very good response, and we are able to get good number of egg collected. And we have frozen also, like in one patient whom AFC was like 2 and 1. In that patient, we collected 8 eggs after 3 months, and we transferred 1 blast, and we frozen 3 for subsequent cycle. But she got pregnant in the first cycle itself. So this is the protocol we follow.
So just to clarify it for the viewers, so what you do is in one cycle, maybe on day 6 or 7, you would do the PRP. Then obviously not within the next cycle, since you're saying you call them after a month. So we skip a month, and in the 3rd month, then on day 2, you would do the parameters and then take them up for protocol. Madhuri, would you like to add anything to this?
I think it's best to wait after doing an ovarian PRP at least for about 3 months, because it would take that much. And I prefer like to do it in the 4th month, because I think the results would be much better because the whole cycle of folliculogenesis does take about 85 to 90 days. That is my take on it.
Thanks. Dr. Padmaja, which patients do you think? Of course, Dr. Padmaja never got introduced, so please let me introduce. She's a consultant in Fertility Clinic, Mumbai. She's been my fellow, and she's a person whom you would just love to have as your associate because she remembers the patients from 10 years ago in complete detail. So, along with their investigations. So yes, wonderful memory and a wonderful person. So tell me, Padmaja, what would you, what do you think? Who are the women who are going to respond to PRP?
Those who are like, there is no endometriosis, there is no fire. If the AMH is like, if their age is less than 35, I think it will be a better response. We will get a better response. There should be no ovarian surgery has been done on that patient, whether it is for endometriosis or ovarian mass, whatever may be. And
so I think my next question then, Naina, is that who are the patients whom you would exclude from PRP? Would endometriosis be excluded? Would ovarian surgery be excluded? Age limits, would there be an age limit to the patients you're taking, or also an AMH AFC limit? Would there be some inclusion and exclusion criteria? Can you just expand on that a little bit?
Yeah, so our inclusion and exclusion criteria, we would prefer patients who are not suffering from autoimmune disease. Their karyotyping, if they are young premature ovarian failures, definitely their karyotyping should be handy. We should know that. And endometriotic ovaries, it's very guardedly. If one ovary is not affected, definitely. But if surgery is done and if there is lingering endometriosis, it is best we don't do it in such patients because it can increase the endometriosis rather than the antral follicle count. And we prefer to do it at least after 2 cycles, unless the patient is, I would not cut off, no age cutoff. Experimental, explain the patient that at 39, 40, 41, your age is the biggest culprit, but it's just a number. They want to still try. They've tried cycles, they've got no fertilization, now they want to try, and we have to do it. Definitely, FSH is a better marker than AMH, what I feel in such patients, because I've seen FSH from 36 going down to 24, and in a couple of months or 3 months, it's just down to 14, 15. So I prefer FSH. AMH variations are very vague, even the quality of testing. So I still prefer FSH as a good marker. And regarding the AMH, as low as 0.02 also you can do it. AFC, no follicle also, because these are the patients who genuinely need ovarian rejuvenation, and we do it.
Tanya, okay, would you like to comment?
I would agree with ma'am. Actually, I've just done one case of the ovarian PRP, and in hindsight, I did it a month later. Travel. So we did get better oocytes, but however, it landed up being a negative cycle. So in hindsight, I think definitely better to wait 3 months, whichever way, as Dr. Fireza is saying, or Dr. Nita or Dr. Naina is saying. For me also, I think FSH was a marker, and for us, we were taking less than 25. And I know there are variable cutoffs. AMH, not really a cutoff. AFC, not really a cutoff, ma'am. Again, we were doing it in the late follicular phase where there was a dominant follicle, and it was easier to see because the other ovary was so small and shrunken. And as you said, ma'am, it was quite difficult because to even pierce through the ovary, it is not that easy. When you're going to go through this little shrunken ovary, you've got to be very careful. So again, I think this is to be done by people who are pretty confident in doing their pickups because you don't want to land up having an injury. So I would say that choose your patients correctly. For me, endometriosis is also a big no. We don't do it, but we do not exclude on the basis of a previous ovarian surgery. But endometriosis I've not done now.
I just wanted to, discuss this aspect that the Greek group actually looked at menopause and perimenopausal patients also in terms of returning their ovarian function, their menstruation, and protecting against disease, cardiovascular, etc., which happen after menopause. Now, would you think that is a valid indication for us to do PRP? What is your opinion? Madhuri, can I start with you and then I'll go around?
Yeah, so basically, I would not prefer doing in a woman who's more than 42 to 44 years because again, you'll have increased incidence of aneuploidies and all, and then the chances of miscarriage also increase. So I think I would prefer doing in a patient who's less than 42 years rather than in a patient more than 42 years.
Nena?
Yes, also patients I have done up to 45 and I've got one result also, but that's one odd case, I would say. I always counsel them that if I do 100 cycles in a 45-year woman, I can get one result. But even if they want it, in spite of all that, I'll do it. But otherwise, 42, 43 is the cutoff.
One of the criticisms against this has been that spontaneously also people even for at 45, at 50 also there is the conceptions. So there are those, aberrant cases which do happen. So one of the criticisms against all these case reports has been that these things also happen, especially if you stop HRT, suddenly the HPA axis goes, HPO axis activates and you have follicular development when pregnancy. And I've had it in a couple of patients myself. So I know that it does happen. And so these are the criticisms to it. But of course, we know how persistent patients are and they keep on, despite our counseling them repeatedly not to go for this thing, but they do. And we have no other alternative but to really, succumb to their wishes and say that, okay, we'll give it a shot and you see. But I think the bottom line is counseling. Unless and until they are counseled, their hopes go up very high, and then that becomes a huge problem. Neeta, would you like to add anything?
I agree. I absolutely agree. I do not take patients who have, as I mentioned, streak ovary or shrunken ovary. And I have found not very encouraging results in women who are like 40, where you don't see any antral follicles. And those patients I have not tried. I don't know if others have tried and got very good results. I have not tried. So my inclusion criteria is that I take patients who have FSH up to 20. I take AMH as 0.5 and I take antral follicle count at least 3. So I don't do patients who have no antral follicle, zero antral follicle with streak ovaries, I do not take, because I explain them that this is still an experimental procedure, and if they consent and they want to be tried for this treatment, we take, because still this is a ICMR, funded research project. And we tell them that these are the findings so far, and if they would like that we try this treatment, we don't know what will be the outcome, because some patients we get excellent response. In some patients, I don't know, even if they are younger, they do not respond. And we do not definitely do patients who have been operated bilateral endometriomas, who've had TO masses, tuberculosis, and had some kind of ovarian surgery for some benign ovarian masses. We do not take these patients for the trial.
Yes, because you'd always be worried for a BOT or any kind of
yes, absolutely.
Now, before I go on to Firoza's presentation, I'll ask Dr. Chaitra one question. Unfortunately, we cut off the intrauterine part of it, but I'll ask her. I want her to, experience on doing the intrauterine PRP. What do you do it for thin endometrium? Do you do it for RIF? Which are the patients where you see results, and what is your experience?
Yes, ma'am. We have got the permission for we have got an ethical permission for something called as an adaptive clinical trial, wherein we take three patients permission, and then we go back to the ethics committee and try explaining to them what are the risks. They don't necessarily want us to say if it was positive or negative, but just that the safety of the patient. So far we have done around 20 patients, and we have unfortunately not got very encouraging results.
Neither in thin endometrium nor in RIF.
In thin endometrium, we have not got. In RIF, we have not yet asked their permission.
Okay, you're not done with so far. Okay, with that, I think because of lack of time, I will stop the discussion here, but we'll go on to Dr. Firoza Parekh, and she'll share her experience with us on intravariant PR.
Can you see my screen?
Not yet.
I'm sharing. One moment.
Firoza ma'am.
Yeah, I'm trying to share my screen. Can you see
Yes.
it now?
Now it's visible.
Visible?
Yes, it's visible.
Okay. So I think, Nalini, the panel has brought about a lot of appreciation, but also many questions have come about. And I'm going to touch upon some of the difficulties, suggestions, solutions, physiology, whether this is too much, too little. So let me just go straight into the topic. Now, why PRP? Why are we thinking of this? We are thinking of this because in Indian women, we are seeing a very significant diminished ovarian reserve, which I'm sure all of us are facing in our practice. And they come forward with either a poor reproductive outcome, poor ovarian stimulation, or a very diminished ovarian reserve. And we all are aware that all of us will ultimately have ovarian aging. But for young women, when ovarian aging occurs at a young age, it can have dramatic and very unfortunate results. And I'm not going to go into the physiology of this, but we know that there is an aging process in the follicle, which can happen due to many, many reasons like upregulation and downregulation of genes. There can be dysregulation resulting in reactive oxygen species. There can be mitochondrial issues, and all these not only decrease in age, but can sometimes impact at a very young age, particularly if there are some karyotyping or chromosomal issues. I am not going to go into the physiology because a lot of people have given very good lectures, but please remember two things. One, when you prepare PRP, the concentration of the platelets has to be at least 5 to 10 times the original sample. And this you have to wet in your lab. You have to do at least 10 consecutive samples to show that your PRP is adequate. Also, the instillation has to be, or whichever way you use it, either for the endometrium or for the ovary, it has to be fresh. It has to be instilled within 10 minutes because otherwise you are adding an analog to stimulate the release of the various factors from the platelets, and these growth factors can get depleted very soon. So the idea is to do your activation very quickly and introduce the PRP very quickly. Now, please remember that PRP does not create new eggs. It only activates dormant follicles. So when patients come to you who are almost at the end of the reproductive career, they come with the hope that, will my eggs increase? They always ask this question, will I form new eggs? Will my AMH increase? And I think it is very important to counsel patients and couples that no, it will not produce new eggs. It will only activate some of the dormant follicles that are there. Now, we have talked a lot about how much is required. Even in stimulated ovaries, in our program, we use stimulated ovaries. We cannot put more than 1.5 to 2 ml in each ovary. And we target 1 or 2 of the dominant follicles so that the PRP does not leak out. This is very important. The leakage, and please remember, even if the leakage occurs, it's not such a bad thing, because the PRP constituents will go into circulation. And it's not just that if you instill in one ovary, the other ovary will not react, because there are so many paracrine functions of the PRP. So even if there is a spill, it will help, although we don't want a spill, because you want to activate the activation system of the follicle. So I'll just go over what we do. This we do because of Boujon's wheel, and that I will show you in a later slide. We do 3 cycles, and it can be either letrozole, it can be clomiphene, or now for the 44 or the 45 patients whom I will talk about, we do a minimal stimulation. The idea is we don't waste the dominant follicles. Every time we do the procedure, we do it as if we are doing an egg retrieval. It's not a full egg retrieval. The patient is not charged as an egg retrieval or as an ICSI cycle, but we do collect whatever eggs we get from every cycle. Our exclusion criteria are strict. We don't go beyond the age of 40. Women who have had past endometriosis or present endometriosis, we do not take, because all the growth factors and the angiogenic factors and the migration factors that are produced will absolutely trigger the endometriosis. We have had patients coming from other centers where PRP was done in significant anguish and pain because of the stimulation of the endometriosis. Women with any kind of acute or chronic PID, women with genital TB, with a past history of some forms of cancer, we do not encourage them to do, because again, these activation products can trigger off any kind of infection and inflammation. So this is the Goujon. I keep talking about it because that is scientific. That is the way we should do it. And these are our results. We did not see, because the AFC, we definitely saw an increase, and I'll show it in my next slide. Most people have responded by saying that the AFC value do go up, and you'll see that the AFC climbs up in the first cycle, more in the second cycle, and even more in the third cycle. Although many have said that AMH is a very good marker for a decline in ovarian reserve, but for an increase in ovarian reserve, at least in our experience, we did not see the significant increase in AMH. Now, all of us who are attending this workshop, please go through Goujon's paper, because it will explain you the scientific implication of the PRP, the way we do it. Because you will see that it takes about 85 to 19 days for the preantral follicle, for the entire cycle to be completed and reach the pre-ovulatory stage. So this is our protocol. I don't need to go into detail. It is just that the first cycle, there is a baseline visit. The second visit is the starting of the stimulation. And then 2B is when we do the so-called egg retrieval and the intra-ovarian PRP installation. Then comes the second cycle and the third cycle. Of course, Nalini has beautifully shown how the installation occurs, so I will not show any video on that and repeat it, but to tell you that we instill it in 2 of the dominant follicles on either side. They may not be dominant, but we try to go for follicles which are more than 14 mm. And we keep the needle in situ after the follicle collapses and then start gently introducing the PRP about 0.8 ml per follicle, or if there's only one large follicle, then we put in 1.5 ml, and we have to do it extremely slowly. We do it over a period of 45 seconds to a minute. It takes a lot of patience, but this is the way you will prevent any kind of peritoneal spill. We looked at any safety concerns. There were none. There were only 2 or 3 patients who had pain which lasted for about 24 to 48 hours. And that was like an ovulation pain. There were no significant side effects. So what were our outcomes? We saw that there was an increase in the AFC, and the increase was more in the third cycle as compared to the first cycle. So that is important, that you see the actual increase over the 90 days. Now, we had 45 women in group A. That was our test group. And this is the data. We managed to do frozen embryo transfer in 32 women. The remaining 13 women, 8 women who had undergone PRP did not reach the stage of embryo transfer. 1 did not produce eggs, 6 did not produce embryos, and 1 produced aneuploid embryos. That is why we like to restrict to the age of 40 and less. Surprisingly and very satisfactorily, 5 women conceived naturally, and 16 of these 32 women underwent embryo transfer. Now, it's very interesting. One of these 5 women had done 11 cycles of IVF, either with failed fertilization or not having conceived through the frozen embryo fresh transfer. This woman was the one who conceived naturally after 2 cycles of IOPRP. She could not do the 3rd cycle because of some social family reasons. And in the 4th or the 5th cycle, she came back pregnant. So yes, you should also look out for natural conception. So we saw that our clinical pregnancy rate per ET was 46%, and the overall pregnancy rate was 44%. The ongoing live birth rate was 35%. Group B was about 51 women who declined the use of PRP. Their clinical pregnancy rate was 25%, but there were many miscarriages. So ultimately, there were less number, hardly there was about 13 or 14% pregnancy rate in the overall group. Now, this gains significance because these are women with POR and DOR who have been actually offered donor eggs, but they had refused to use donor eggs. Again, I'm repeating that prenatal follicles take 85 to 90 days to mature, and that is the reason why we use this protocol. So we saw that there was an improvement in AFC, but we did not see a significant alteration in the AMH. And that is because AMH is produced by the tiny follicles and the early prenatal follicles. So that is why you may not see the effect of AMH right away. Nalini, just one thing to add. For the Greek study where they were looking at improving the life experience of women who were menopausal, this effect of rejuvenation, in my opinion, will not last more than 1 year. So if anyone comes to us for ovarian rejuvenation for improving the life conditions, it has to be told that the effect of PRP will not go beyond 6 months to 1 year, and therefore they may have to repeat the PRP if it is for life improving conditions.
And that too only if in some patients, it will not necessarily be there in all patients. Absolutely. They may not even rejuvenate at all. And absolutely. I think in the Indian condition, they come more for fertility rather than for menopausal reversal.
Absolutely. I agree with you definitely. And that ends my talk. And I will urge of you to take advantage of the Fertility Sterility Indian edition, which gives you free access to 3 years of articles from Fertility Sterility. Thank you so much for calling me, and thank you for a very patient hearing.
Thank you so much, Firoza, for sharing your wonderful paper. And you know, this is such an upcoming thing. Everybody has their experiences to share, and I think at the end of it, maybe within 6 months to 8 months or even a year, we'll know where we stand and how we have to go forward, and how our patients are actually different from the Caucasians or the Western patients, because there are differences amongst all groups, and I think offline workshop that I do, we should be able to have something more interesting. Thank you so much. Thank you, Madhuri, Firoza, Anita, Naina. Thank you so very much for being here right through. Thank you.
Thank you,
ma'am, for the wonderful.
I'd like to close the workshop.
Thank you for the wonderful workshop.
One question, I think, Tanya.
Thank you very much for that, ma'am. Firoza ma'am, can I just ask you, the needle that you were using was the standard single lumen, or do you prefer the double lumen?
Single lumen, 17 gauge, which we use for IV egg retrieval.
So with the same, once you finish, just push in?
Yes.
Can I just add something here?
You know, when you're doing with the pickup needle, what happens is that when you're pushing in fluid, sometimes it comes back. So you're not, I mean, I don't like using that. I use a cyst aspiration needle with which you just push and then push the plasma, and that's it. So then you don't have to clamp anything. In that, you may have to clamp the part that is coming into the tube. Nana, which needle do you use?
The simple egg retrieval needle, 17 gauge.
No, with the aspiration, or just the cyst aspiration without the suction?
No, without the suction. Without the suction. Yes.
So here is a catch I just want to add. So when you inject through the egg retrieval needle, what happens about, you have to quantify the amount which is required to be really going at the tip of the needle, because about 0.5 ml of that fluid will be left in the tube only. So to flush that, the amount of fluid remaining, you have to adjust that, finally you have to push little bit of saline or maybe
plasma, actually, that's
yes,
what you push.
Plasma. What you do when you're preparing the PRP, you keep some buffered non-PRP available, say about 2 ml. And that is enough to kind of empty out your entire needle.
Yes, yes, absolutely.
0.2 or 0.3 is the dead space in the needle. This is aspiration. You can probably add another 0.2 for the, the double lumen needle. So 0.5 is what you would need, not more than that.
Yes. So you have to keep that margin.
Yeah, you have to keep the margin. Yeah.
Yes.
You have to keep
the
buffer ready.
You were saying something? Anybody was saying something?
No, I said that when you're preparing the PRP, Nalini, it's a good idea to keep the buffer ready because that will prevent any reflux of the actual PRP from coming out.
We keep the plasma because the buffer and all gets used, buffer gets used up, so we keep the plasma.
Yeah, so buffer is the plasma only. It is the non-PRP plasma.
Can I ask a question?
Yeah.
You aspirate the follicle,
right?
And in the same follicle, you go and inject.
Correct.
So you see the follicle coming up again with the fluid inside.
Absolutely.
And then keep it like that, about 1 ml or 0.5 ml, whatever you
Yeah.
inject. The remaining, then you inject it in the stroma surrounding, or only in the follicle that you have.
No, what we do is because we have these dominant follicles or 1 or 2 follicles. Suppose there's only 1 dominant follicle on one side, then I will put 1.5 to 2 ml. And that space comes up very nicely when there is a dominant follicle. You try it sometime with a stimulated cycle, just with clomiphene. You will see how beautifully that comes out and there is no intraperitoneal spill. So if there is only 1 dominant follicle or 1 follicle on either side, we will put 1.5 to 2. If there are multiple,
and the stroma will absorb this.
We don't put it in the stroma.
No, see, I have one contention against this, and I actually, in an initial paper, some paper had written this, it was not from, I think it was within India, that paper, that you put it into the follicle. Now, look at it logically. When you're putting your needle through the follicle, you're making a puncture there. So when you're putting the PRP, it is going to come out from there. But what does happen, and I've seen it happen because I did it, is that the secretions and the antrum again starts refilling. Now, what is the quality of that particular oocyte? I don't know, because you've inserted your needle and wherever what you've touched, God alone knows. That part I don't know, but it is just logical that when you're puncturing something, well, the fluid from that, whatever you put in, is also going to come out. How effective that is, I don't know. So logically, you should put it into the surrounding stroma or the subcortical or even intramedullary. It has been said that. And of course, when we're putting it, do we really know where we are in the cortex or in the medulla? So, let's be honest about it.
Yes, absolutely.
Nalini, I'd like to respond to you. Nalini, I'd like to respond. I'd like to respond to Nalini.
Yes, please.
Yeah. No, this work is absolutely honest. There is, I've even shown who have not undergone retrieval. What happens is the platelets are, as you know, the biggest factors which cause angiogenesis and also seal up wounds. In fact, whenever there is a wound, the first thing that happens is the platelets rush to that area. So these platelets serve as a glue to actually cover up the follicle. So without dishonesty, I can tell you that we have had no leakage into the peritoneum when we have done this technique.
And you observe the follicle after 2 days or 3 days, whether it's full or it's collapsed again?
No, we don't.
No, Naina, what happens is, let me tell you, there is fluid, but I think that is the antrum which has gotten reconstituted, the antral fluid which has gotten reconstituted. I don't think it is what you have put in, because that would have gotten absorbed by that time into the granulosa cell or wherever. So there is a refilling of the antrum, as happens in a cyst aspiration. You know that when you aspirate the cyst, you see the patient a few days later, little bit of fluid is back again in the cyst. It doesn't completely collapse. So I think that's what's probably happening. That is absorbed, but the antral fluid starts reforming.
Super.
Thank you, everybody. Wonderful, wonderful discussion, and I hope to have it face to face now next time, and then have it for a longer time.
Yes.
Wonderful, wonderful. Thank you, ma'am. Thank you.
Thank you, everyone.
Thank you, ma'am. That was a wonderful discussion.
Well, I hope you enjoyed it. It's something for us to do.
It was very wonderful, ma'am.
Thank you.
Thank you, ma'am.
we are going to take a photograph. Please just stay there.
इसको 40 डिवीजन लगा दो। अरे 40 डिवीजन वो पोडियम डाल दो। हो गया ना?